Good afternoon. And what an absolutely wonderful afternoon it is. Bernie, we are here to applaud, to celebrate, to thank you for all that you have given to our department, to Hopkins, to Baltimore, and to the children of this country and the world. Thank you. I'm a child of Maternal and Child Health and the Maternal and Child Health Bureau. And the name Bernie Guyer was a name that I knew from the time that I started in my training. I knew of his writing. I knew of his commitments to child health and infant mortality reduction. And over the years, long before I ever knew that there was a possibility that I too might come to Hopkins, I had the numerous opportunities to be at meetings with, and at times, as I became older, to be on panels with Bernie Guyer. I was speaking with my son the other evening, and he, who is in the IMPH program, and he was down for 2 weeks, and he said, you know, when you first came here, you seemed very anxious. I said, what was it? He said, was it coming to Hopkins? I said, well, I was coming in to be the chair of a department that Bernie Guyer had chaired before. And it was a daunting task, and it was an intimidating task. But it was also one that Bernie humanized. And one story about him, and then one other, and I will turn it over. So the very first time that I came here, you know, I was coming to be interviewed, and people were taking me around and feting me here and there, and Bernie was going to take me out to lunch. He said, I'll take you to the best lunch in Baltimore. Remember that? We went down to the deli, stood on line, and waited for our turn for a corned beef sandwich. That actually is what sold me on Baltimore. Being in Minneapolis, one did not get corned beef that was real corned beef on real Jewish rye. But that was a different story. When Bernie decided to retire, he stood up in faculty meeting and he said, I plan to retire. Now, that may not sound extraordinary to many of you, but for those who have lived here at Hopkins, most people don't retire. They just sort of fade away, and they go from 80%, 70, 63.5% down to 49%. And Bernie said, I want to retire. And one of the things that I know, and that makes it particularly wonderful, is that for him, there's an entire life, there's an entire world, there's an entire set of interests, of which his passion for academics and his passion for research and his passion for Hopkins is but a part of his whole life. And that, I think, is worth emulating. When I was just starting in my field in adolescent health in the early 1970s, I wanted to hold a national conference, and there was a very esteemed adolescent medicine physician, J. Roswell Gallagher from Boston. And I thought, I'm going to invite Dr. Gallagher to come to Minneapolis. And I called Dr. Gallagher and I said, would you come? And he said, I think you have the wrong person. I said, why? I said, aren't you Jay Roswell? Yes, but I think you have the wrong person. He said, I need to tell you that my expertise is roses. I don't have expertise any longer in adolescent health. If you would like me to come and talk about roses, I have an extraordinary fund of knowledge in roses. And obviously, I've never forgotten that. I've never forgotten that because while roses are not my thing, having a life beyond this work is. And Bernie, you really represent that kind of balance. You represent a balance of family, of home, of faith, a joy of life, an ability to participate and celebrate and live in so many facets of it. So it is really for you that we come together to thank you for everything that you bring to us and our world. I'd like to turn it over to Professor Cynthia Menkovitz, who, with Donna Strubino and a small army of other people who have worked to really put this day together.
Welcome, everyone, and good afternoon. It's truly an honor to be here joining all of you in celebrating Bernie's extensive contributions to maternal and child health and to the careers of so many scholars and public practitioners, many of whom are here today. There are many aspects of Bernie's career that we could have chosen to focus on. His incredible leadership roles here within the Bloomberg School of Public Health and on national committees, his work on early childhood health, immunizations, injury prevention, and strategies to reduce infant mortality, or his remarkable ability to connect the academic and practice worlds of maternal and child health. As Krieger chair, though, one of the distinguishing aspects of his career, both on faculty and as the chair, and the one that we'd like to highlight this afternoon, is his role in mentoring the next generation of scholars and public health leaders. Today, we'll hear not only from family, but also from former students and faculty, all of whom are now colleagues. In helping to plan today's festivities, an important first step was to identify who might speak at the symposium. When we initially reviewed the list of students and faculty with whom Bernie interacted in his years in the department, we realized what a daunting task this was. Imagine more than 27 single-spaced pages of talented and highly regarded graduates since 1989, and that's not including the faculty. And personally, as one of Bernie's faculty recruits, I feel particularly privileged to be a part of this program. His wisdom, mentoring, and ongoing collaborations have been invaluable in shaping my own career. Each of today's speakers has been invited because of their connection to Bernie and in keeping with his vision for the future. Many already are established leaders in their respective fields, and others are newly emerging. What they share in common is that they truly represent the breadth of Bernie's influence in multiple content areas, in groundbreaking conceptual thinking, throughout the world, domestically and globally, and personally, as he has influenced each of theirs and my own career paths. In introducing today's speakers, Donna and I will share with you a glimpse of their special connection, and we're certain each will share a bit more. Welcome.
As Cynthia said, we're going to be introducing the speakers for today, and I'm just delighted that so many of them have been able to come here today. Many of us who are here today have worked with Bernie for a number of years, and I know I personally, over more than 20 years, I hate to admit, have worked closely with Bernie and have gained wisdom from Bernie in many areas. The speakers who are going to be talking today are actually going to reflect specific areas in which he has imparted wisdom. And so what we're going to do as we introduce the speakers is to highlight what we think reflects Bernie's wisdom to them, some of the work, just very briefly, that they did with him while they were here, and then they're going to tell you a little bit more about the work that they're doing currently. So our first speaker is Ashley Schempf. She's a graduate of Population, Family, Health Sciences, Population, Family, and Reproductive Health, after the change of the department's name. And she actually reflects the perspective that Bernie had on rigorous data and the use of science, particularly evidence. In maternal and child health and public health practice. While she was here, she worked with Bernie on a project in Delaware as a MCH epidemiology fellow. And in that project, she and Bernie looked at the reasons for the increase in infant mortality in Delaware. And they were particularly interested in whether there were racial differences in the increase. And I think one of the things that they found in that analysis that was particularly surprising, that it was among largely low-risk women who aren't usually the focus of public health interventions where the increase had occurred. Ashley is now, she was a postdoctoral fellow at NCHS, National Center for Health Statistics, and she is currently, she just joined last week the Maternal and Child Health Bureau as a research scientist in, you said data, and the name of it now is Data and Performance Monitoring? Program development, and it's soon to be epidemiology and policy evaluation. So she's going to tell us a little bit about her work. Ashley?
So my relationship with Dr. Geyer first started in probably February or March of 2002. I had applied to the doctoral program here after doing some undergraduate work in health policy and childhood immunization, which Dr. Geyer is a leading expert. And I'm not sure if many of you know, but in the 1990s there were pockets of underimmunization where we experienced some outbreaks of vaccine-preventable diseases, and Dr. Geyer was the first to show that this was really the result of missed opportunities to vaccinate. So it wasn't that children weren't getting medical care. There were missed opportunities within the medical system. And so realizing this led to increases in childhood immunization, and now we're at record levels, and disparities have been eliminated for racial ethnic groups and by poverty. So I get this phone call one evening from none other my own American Idol, and I mean, my life was research. Now I'm more balanced, but I was just through the roof, excited and speechless and dumbfounded, and I probably sounded like an idiot, but it wasn't an offer at that point, but just a call to interview. But it was so personal and nice that I knew I would come here if they would have me. So I enrolled in Health Across the Lifespan, the intro course to the department that Dr. Geyer developed and co-taught, and felt right at home. I then worked with him on an immunization paper with Healthy Steps data. And then, as Donna mentioned, I worked with him as a trainee on the MCH Epi grant, where we collaborated with the Delaware Department of Health. And through Dr. Geyer, I really learned the importance of community academic partnerships and developed great respect for practitioners in the field who are really doing the heavy lifting and trying to apply the knowledge that esteemed institutions like Hopkins are producing. This interest in applied research led me to work with epidemiologists and program specialists in Hawaii, which I found greatly rewarding, and I still am pledging to take data to action and advocacy. You also might not be aware that Dr. Geyer established the first MCH research unit within a Department of Health to influence programs and policies through evidence-based research and evaluation, and during his tenure at the Massachusetts Department of Health, he published 6 articles in the New England Journal of Medicine. I'm just hoping for one. And he covered injury, reproductive mortality, and residential care for handicapped children, among other things. So one of the most obvious and inspiring qualities of Dr. Geyer is his passion for social justice for vulnerable groups, specifically mothers and children. And Dr. Geyer frequently uses this quote that I'd just like to read. A child is born in an utterly undemocratic way. He cannot choose his father and mother. He cannot pick his sex or color, his religion, nationality, or homeland. Whether he is born in a manor or a manger, whether he comes close-fisted into the world, his fate, to a large extent, is decided by his nation's leaders. He and now I too find this very powerful in really conveying the accident that is birth. There's no choice involved in the circumstances of your birth, and thus how we're all responsible in protecting and giving voice to the vulnerable and ensuring equity of health and opportunity by these characteristics that Itzhak Rabin mentioned: gender, race, wealth, region, religion. Dr. Geyer has been one of the pioneers of the life course approach, that health in early life has lasting effects throughout other life and developmental stages, and in using that evidence to advocate for investments in maternal and child health. He employs a multiple determinants public health framework where health is not just a function of medical care, but more broadly of social, economic, environmental, behavioral, and cultural factors. And he's devoted to improving health and equity from the beginning of life, particularly given those life course consequences. Although he is quick to point out that health in childhood is not deterministic, that there is amazing resiliency of children when supportive resources are in place. So all of these principles have definitely inspired and strengthened my own commitment to investigating socioeconomic and racial ethnic disparities in perinatal health and the policy relevant strategies to reduce them. So I just wanted to introduce a few lessons learned that will be part of his legacy for me. Dr. Geyer is a visionary leader, and he really insists on big picture thinking. What are the implications? What's the so what factor? Where's the biggest bang for your buck? That's really what population health is about, the broader determinants beyond the individual, like the economic return to universal early childhood investments, which he's been involved in. Secondly, Dr. Geyer really knows the art of storytelling, nonfiction, of course, maybe fiction too, I'm not sure. But being able to set the scene, paint the picture, and deliver a message that's concise, simple, accessible to the broadest audience possible. One of those New England Journal papers very simply and elegantly showed that the high infant mortality rate here versus Sweden could be entirely attributed to excess low birth weight here. So it wasn't for lack of exhaustive medical care that reactively seeks to save small early babies once they're born, but instead the non-medical upstream determinants of early deliveries, what I believe has more to do with our social than medical system. Unfortunately, this fact hasn't changed, so Dr. Geyer, you still have some more work to do. Another lesson I've learned from Dr. Geyer is knowing when good enough is enough. And although he's not an economist, he clearly understands the diminishing returns and opportunity costs to perseveration and perfectionism. Problems that I and many other type A students struggle with. I've heard Dr. Geyer say to many students that the best dissertation is a done dissertation. So he often would tell me to move on and get it off your plate and onto someone else's. And I have to say that when I can let go, it does really feel good. So I just wanted to go over an applied example of these lessons in big picture, accessible storytelling with data from my own line of research. And so for some high impact bottom line figures that Dr. Geyer appreciates, you're all probably well aware that Black infants are more than twice as likely to die within the first year of life than white infants. And I did some calculations, and if Black infants had the same risk of death as white infants, about 5,000 Black infant deaths could be averted annually. And with an average life expectancy of 73 years for Black individuals, this translates to about 350,000 years of potential life lost on an annual basis. Stan, I don't know if you're here, or Vladimir, don't correct me now, we'll do it later. We know that excess preterm birth among Black infants, particularly very early birth, is the proximate cause of this disparity, and that those very early births that do survive will face a higher burden of health problems and developmental delays. There's been a general inadequacy of individual level factors like SES, behaviors, and medical risk factors in accounting for these disparities. So I wanted to explore some relatively untapped state-level variation in preterm birth, so taking a broader, like, population-based approach. So this is a map of the Black preterm birth rate by state, and I decided to focus on the Black rate and not a disparity measure, because you can achieve a low disparity by having a high white and or high Black rate, and that's not what we'd like to achieve. We'd like to be lower for everyone. So here you can see that the rates are highest in the South, particularly states that border the Mississippi River, and lowest in New England and Northwest. In fact, in North Dakota and Vermont, the Black preterm birth rate is actually lower than the white preterm birth rate. However, there are very few Black births in these states, so the numbers aren't actually reliable, but they are more stable in Maine, and there the disparity was very low, less than a 10% difference. So if all Black women could have the outcomes of those in Maine, the overall Black rate would equal the national average for white women. So what explains this regional variation? We think it may have something to do with the different social significance and meaning of race in the South versus the North, and particularly the Northwest, where there was never really a history or legacy of slavery or discrimination. A lot of people of color will tell you that how they're treated varies dramatically by the state that they're in. And we know that how you're treated affects your stress response, and stress is thought to be related to the immune and vascular pathways which lead to preterm birth. So what is an indicator we could use to capture this sociocultural significance of race? And I'm going to give Dr. Bashai credit here. He gave me this idea to look at the state level interracial marriage rate, which is defined as the percentage of Black marriages to whites. And it's suggested in the sociological literature as a good barometer of race relations and integration. A recent example in Louisiana, where the Justice of Peace denied a marriage license to an interracial couple, kind of highlights how this is still an issue and probably could be a good indicator of race relations. And there are also still segregated proms in some school districts in the South. Morgan Freeman produced a great documentary about hosting an integrated prom. He had offered for 10 years to integrate a prom in his school, alumni school in Mississippi, and they never accepted until last year. And even then, the white parents still had their own prom. Because marriage is the most intimate of unions, like interracial marriage can be considered a sort of ultimate indicator of integration and the sociocultural insignificance of race. It correlates well with the history, social significance. Anti-miscegenation laws never existed in many northern and western states and were repealed only after a 1967 Supreme Court decision in most southern states. This indicator may reflect dimensions of interpersonal as well as institutional discrimination, institutional factors that govern the likelihood of racial interaction and dating by neighborhoods and schools, such as redlining and housing discrimination. So this map shows the exploratory correlation between state-level interracial marriage and the Black preterm birth rate. So the larger the circle, the higher the interracial marriage rate, and the deeper the blue, the higher the preterm birth rate. So you can see that they're kind of inversely correlated. Interracial marriage is much lower in the southern states, where the black preterm birth is higher. And conversely, interracial marriage is much higher in northern and western states, where the black preterm birth rate tends to be lower. Of course, poverty also has similar regional patterns. It's higher in the south, and so that's an important thing to control for. I'm just going to skip over this. I don't think it's really that necessary. So what we find in race-stratified models controlling for individual and state-level sociodemographics and county-level segregation indices, as well as health resources, is that interracial marriage does affect only the black population. A 1 standard deviation increase reduces the odds of preterm birth by 13% with no effect for women, for white women. And this is consistent with the hypothesis because the sociocultural significance of race should not affect the majority population of white women. And these findings are consistent with others on the effects of interpersonal discrimination and segregation. And this just adds another contextual layer of evidence. And it suggests that improving the state racial climate, increasing social integration may reduce disparities. And Dr. Bashai likes to say this is kind of evidence of the real flesh and blood consequences of discrimination. And there are lots of sensitivity checks, so I'm not sure you care about this right now. So I'm just going to say that the challenge, of course, is if this is indeed a robust effect, the challenge would be to affect programs and policies that promote integration and acceptance. And I think there are various school-based programs that help to foster empathy and social-emotional skills in early childhood that could help combat this issue in new generations going forward. But if you have other thoughts, feel free to intercept me afterwards. So I hope I was able to tell a story and keep it simple and accessible and hit the high notes in a big population health approach. I'm also sure it's a bit controversial, and that's not one of Dr. Geyer's tenets, but that is the nature of research, so I thought I'd put it out there. Dr. Geyer, for your gentle spirit, your mentorship, vision, and leadership, and decades of research, action, and advocacy on behalf of mothers and children, we're all grateful. Please smell those roses. And I can only humbly hope to follow in your big footsteps. I'm sure they're size 20 or something.
Thanks very much, Ashley. Our next speaker, Kamala Mistry, reflects Bernie's commitment and contributions to early childhood health and development. Kamala has worked with Bernie on several projects, including the National Evaluation of Healthy Steps, and I see some friendly Healthy Steps colleagues in the audience. And most recently, she's been working with Bernie on developing a conceptual framework for thinking about implications for policies and programs for early childhood health. The exciting news is she recently successfully defended her PhD thesis, and she'll be starting in July as a general academic pediatrics fellow across the street. So welcome, Kamala.
Good afternoon. Thank you for inviting me to speak today. I've had the amazing opportunity to work with Dr. Geyer closely for many years. I've learned so much from Dr. Geyer, both personally and professionally, so I thought today I would share with you Dr. Geyer's retirement top 10 list. And today's category is the top 10 things I've learned from Dr. Geyer. As you will see, some of the lessons are practical and some are more philosophical in nature. So number 10. The best dissertation is a done dissertation. I think you'll see some overlap in my slides and Ashley's. As Cynthia mentioned, I recently defended my dissertation, so the experience is fresh in my mind. During the last year of doctoral studies, as I was knee-deep in analysis and writing, Dr. Geyer reminded me often that the best dissertation is a done dissertation. I guess in some ways the advice served as an invocation to action. The dissertation process was a marathon, and he stressed reaching the finish line was just as important as all of the thinking along the way. Though one can always find excuses and distractions, he reminded me that focus and discipline were ultimately needed to get it done. I'm certain that I will take this advice with me throughout my career, as I hope there will be many more endeavors and many more finish lines. Number 9, it's okay to say you don't know. So early on in the doctoral program, Dr. Geyer met with all of the second-year child health students to help us prepare for the oral portion of comps. He told us that although we should be fully prepared, sometimes we would face questions that we did not anticipate. He told us that it was okay to say that we didn't know, and that the purpose of being in an academic environment was to be challenged and push beyond our comfort levels. He reminded us that being right was not the goal, but learning from seeking answers was most important, not just for comps, but for as we moved forward in our careers. Number 8, be prepared, don't ad-lib, which I just heard. Dr. Geyer often underscores the importance of being prepared and taking the time to think through what it is you're trying to communicate. Over the years, he has highlighted the need for proper preparation in regard to knowing the facts, understanding the context, and having thought through questions that may arise. He stressed that preparation is vital if we, as students and future researchers and practitioners, hope to someday effectively communicate our vision to the world. Number 8, don't get bogged down, which I often hear still. In our most recent project with Dr. Geyer, in which we've worked together on a paper, he has taught me that no one person is expected to have all the answers, and it's important not to get bogged down and attempt to solve all the problems on your own, but rather that learning comes in the exchange of ideas with others, and it's important to collaborate as opposed to hunkering down. And ultimately, through this process, you yourself deepen your understanding and create a more meaningful insights. Number 6, get the argument right. Throughout our work together, Dr. Geyer has always highlighted the importance of taking the time to get the argument right. A sound argument serves as a tool to translate research into policy and practice. Being able to clearly articulate how inferences are drawn and conclusions are reached is perhaps the central step for making the connection between science and policy. Though this may seem obvious, getting the argument right is often not easy, but I've learned from Dr. Geyer that it's time well spent. With leadership, number 5, with leadership comes responsibility. So over the years, Dr. Geyer has over the years in doctoral seminar, we've had many discussions about leadership and defining the important attributes of leaders. He's continually highlighted that with leadership comes responsibility. He's taught me that this sense of responsibility and integrity must be reflected in the way you guide and the decisions you make. Number 4, always listen. This I have learned by example. Listening is key to being an effective leader. I've had the opportunity to attend numerous local and national meetings with Dr. Geyer and see him in action. There are always diverse opinions around the table, but through listening, he's able to forge open discussions among even those who disagree. He has an incredible ability to be present and to guide the conversation, and I hope that this is something I can emulate, because I've seen firsthand that listening is key for developing a shared goal and for action. Number 3, an appreciation for the big picture. So as Ashley mentioned, perhaps one of Dr. Geyer's greatest legacies is instilling in his students an appreciation for the big picture. He has taught us to always ask, so what? And in doing so has encouraged us to truly think through how our work is relevant and how it connects to the current thinking in the field. As certainly his students know, Dr. Geyer has an amazing ability to get to the heart of the argument by asking the right questions, which always seem incredibly obvious, but only after he's asked them. Number 2, a commitment to the field of maternal and child health. Dr. Geyer's passion for improving the lives of mothers and children is apparent in everything he's done throughout his career. It is a deep commitment that drives his need to always push and ask new questions. His spirit is infectious, and it is through watching him that I and so many others have been inspired to carry on this sense of inquiry and also to reach beyond to further his vision of improving the health of mothers and children. And finally, number one, teaching is connecting. So this past year, I had the opportunity to serve as a TA for Dr. Geyer's course, Child Health Seminar. Through this experience, I learned that teaching is about connecting. Dr. Geyer created an environment in which students could openly think and contribute to each other's understanding. He was able to do this by meeting the students where they were. He would engage with the students. He would build on what they were saying. He would ask questions. He would raise issues to extend their knowledge and understanding. But in doing this, the ideas and the concepts remained their own, and he encouraged their natural curiosity and sense of exploration. And learning in some ways became the byproduct of all of this. He created a sense of openness and comfort in the classroom among his students, and they learned not only from him, but also from each other. So in closing, I want to share a story, a short one, from the last day of class, Dr. Geyer's class. The students had created a hand-drawn card for Dr. Geyer to celebrate his retirement. When they handed him the card, one of the students, Megan, who's here today, said, "Dr. Geyer, we wish you the best. We look up to you so much." Well, I echo this, and I just want to say to you, Dr. Geyer, that I've benefited so much from your mentorship and from your teaching. You are a true visionary, and I feel so lucky to have had so many opportunities to work with you and learn from you. Thank you for always asking the hard questions, even at my dissertation defense. You've inspired a love of learning and a commitment to finding the answers to the hard questions in the next generation of researchers. And I hope you know how much you mean to all of us. Thank you.
Thank you, Kamala. Our next speaker is Michael Jonas. He's a Doctor of Public Health graduate of Population and Family Health Sciences. Right. I know we didn't change then in the department. And Michael actually is an interesting combination of backgrounds. And he reflects, I think, Bernie's focus on innovation, creativity, and follow your heart and passion. Michael has two passions. The first is for art. The second is for child health. And Bernie strongly encouraged Michael to combine those two passions. And for any of you who were in the department when we used to be at Hampton House, we had the wonderful opportunity to be able to walk down the hall and see Michael's posters, or long, I guess, posters? Murals of children, and that were created by youth in Baltimore City. We had the opportunity to see them every day. So Michael's going to tell us a little bit about that work and what he's been doing now. He's currently an assistant professor in family medicine at the University of Pittsburgh School of Medicine.
Good afternoon. It's a tremendous honor to be here and to share the progress of this project that I'm going to talk to you a little bit about, and attribute it, clearly to the chance that Dr. Geyer took on me when I first came to an open house at the DuPont Circle campus. To be honest, here this is a celebration. So to be transparent, I was in Afterwards Cafe in DuPont Circle. I had decided not to go to medical school. And I was currently in my 4th year of running after-school programs in public housing neighborhoods in Washington, D.C. And I heard about this open house for the School of Public Health. And I thought I would just walk over because my office was around the corner, and Dr. Schoenrich and Dr. Geyer were there. And when I came in, I was probably talking a little bit this quickly as I am now, and was pretty excited to learn about the field. And as I talked about my interest in the arts and my commitment to the work I was doing, many people in the field of health and public health would kind of squint their eyes and kind of wonder what I was talking about and some of the arts background. And Dr. Geyer leaned forward and Dr. Schoenrook leaned forward. And it was really that opportunity that Dr. Geyer said, I don't really know what to do with you because you have an art degree, and I don't know how that fits in the direction we're taking, but the work you're doing in these neighborhoods, let's start off by taking some classes part-time and sort of see how things go. And it started a relationship that has truly changed my focus and direction. So I came as, I'm a painter by training, and I ran after-school programs in urban public housing neighborhoods for about 8 years, and that's where I really developed on a first-hand basis many of the same issues that were talked about here, the differences that exist within communities and the power of disparity and discrimination, and the health and wellness, and how that impacts the health and wellness of youth. I also had developed through that time a strong dedication and commitment to social justice, action, and passion. And the same quotes come up, so I'll probably skip some, but clearly the point of what's been talked about is Dr. Geyer said, this is great research, but so what? So what are you doing? So where does this go? How is it being applied? And that has really rung true to me throughout. I'd also had, at the time, I had been started the MPH part-time, and I kept talking with Dr. Geyer and a few select faculty, Dr. Ocampo, another one who was willing to listen. But I kind of had this parallel life. I was doing arts-based work and exhibiting art, and I was training as a public health professional. I was thrilled about the methods and practice that I was learning here, but then I would kind of go back somewhere else and do these other things. And it was Dr. Geyer who really encouraged me to think about how to combine those two directions and how to think about how that might apply to public health. So I got the MPH, which was pretty thrilling. I didn't think that would ever happen. That was exciting. And at the end of it, Dr. Geyer had been kind enough to say, well, why don't we have coffee on, I think it was every other Thursday morning at about 8:15 in Hampton House. So it really started around the Hampton House Cafe. So there were lots of 8:30 in the morning coffees, and I think as Dr. Blum said, a few trips to Atman's was pretty fantastic also. That helped really well. And the questions weren't just about what are my research focus, what were the specific aims, but how is my family? What kind of things was I interested in doing with my future, and what kind of things was I most passionate about? And that's where it started, this combination. So I'm involved in a number of projects, as we all are, focusing on child health and wellness, asthma prevention in kids in urban areas, but I'll be sharing with you a bit more about the arts project that is really attributed its development to Dr. Geyer's support. And really trusting inspiration, which came up before as well. So trust when you have that thought and that passion, and be willing to kind of stand alone sometimes as well. So Dr. Geyer is, I think, the first faculty member here that I actually shared my paintings with. When I did that later on, people still were like, actually one faculty member I did say, it's not really my work after the reaction was so bizarre. I said, it's my brother's work. I said, it's not mine, just kidding. You know, because it's so much a part of who I am. So I do a lot of writing in my work. They're basically visual journal entries, lots of pieces here that describe sort of my experiences, interactions that I have. And Dr. Geyer always leaned forward, always asked why, asked about the materials, always asked about who am I sharing this? Did I share them with the community individuals that I was talking with, and really encouraged that process. And then became a little safer to share more about the Visual Voices Project, which when I was just coming out of college, I was interested in volunteering and working in a few urban areas in Pittsburgh where a number of my friends lived. And when I came into the neighborhood, people thought I was a cop. So they'd say 5-0, and they'd treat me like a cop pretty well. So that isn't great community building either. So I found that after some time and some challenges that I was able to get some art supplies together, and I had the great opportunity to bring some of those art supplies to one of the public housing neighborhoods, and the reaction was totally different in the community. The guys who were hustling on the corner would kind of leave me alone because I could say, oh, you want to paint, don't you? And they'd say, no, we don't want to paint at all. And the kids would really come out, and it just provided an opportunity to get to know each other in a very, very different way. And them to know me, to ask lots of questions. I often joke, and this has happened countless times since, but kids will often ask through some of these relationship building, just sharing activities, talking about our hopes and dreams to the future, focusing on the assets of their community, where we often have, certainly in research, have a tendency to focus on the negative aspects of neighborhoods. We'll learn about the things that aren't working so well in the neighborhoods, but trying to give the kids a chance to brag about that, but I'll get back to the other piece in a minute. So this is just some introduction to sort of how the project works. It looks a little bit like controlled chaos, where kids are asked commonly to paint about their hopes and dreams for the future. And from that, we find out some fantastic things and dreams that they have. and also find some things that they're interested in sharing as well. The kids have to share all the materials, hopefully take their shoes off if they're running around, and generally it's a blast. So then this is pre-public health, by the way, so I didn't expect it to really grow anywhere. And we felt that it was really important, or I felt when I was doing the project, much like my work, to find a way to share that, what they were painting with other kids. So developed kind of from art school, a fairly formal but structured way that's fun and open, whereas you can see young kids and older kids can reflect on the work that they're sharing, things that they're painting. So the young girl in the front here was saying how she liked the colors and the way they design, but some of the other kids were talking about how gangs were more of an issue in their rural North Carolina community, but they were all able to participate that, not in a way that was judgmental, but learning about it together, and completely fun. So just as a quick example, as the way the project is developed, you might ask kids about their hopes and dreams for their community. One kid in a neighborhood painted these bins on a corner, and he said there would be bins for guns, bats, and knives. And so what do you think the other kids said around him when he said that you could have these on the corner? He said they thought it was ridiculous, right? So kids would just reach in and take out the gun or take out the bat. And he said, Mark said, no, they would have these sharp metal things around the top, so you couldn't take things out. And they're like, yeah, but then you could cut through the back. And he said, no, it'd be thick plastic, and we put it by that old lady's house, and she's always out front, and people would always see. And then they just start chatting and chatting and chatting. Well, as a facilitator to that process, that was a pretty powerful experience for even the Weed and Seed coordinator from the Department of Justice who funded the project pre-public health to oversee and participate in this discussion. And the next day, they were really thinking differently about some of the reactions, because I didn't ask about weapons, I didn't ask about violence. I just asked about their dreams for the neighborhood. So from a research capacity, it also showed, and I think from the work that I learned from Dr. Geyer and participating as a TA in health across the lifespan, that there's an untapped, misunderstood way to engage these key developmental phases. How do we engage that voice in a way in its true expertise? And it sort of seemed like this might be a good direction to head. I found over the years that some kids, some people like to write, some people like to draw, and I've done both. And so the kids have an opportunity to share what they're doing and what they're thinking, similar themes, but by drawing and writing. And I think when I was talking to Dr. Geyer about this originally, it was funny that I shared that I often give Tootsie Pops because it keeps their mouth shut for about 10 minutes, just long enough to kind of get into the project. But this is where he, as a pediatrician and his immunization work, really brought a lot of my interest in this project and helped me think still how to translate into this, potentially into a research capacity. And we combined the kids' paintings, writing sort of in a collage format, cutting them into strips and sewing them together. This is sort of a fancy depiction of how that works with the writings on top. And this is sort of how it looks in general. So this is an example of what was hanging in Hampton House, which, if you can imagine, for me, is a bit of a fish out of water. The opportunity, and Dr. Geyer saying, well, why don't we hang, some of this up in the building? And I thought maybe 3 or 4 feet somewhere in a corner, and then he put up 45 feet of the exhibit in a main entrance area downstairs in Hampton House. And it was just an incredible affirmation and support to pursue this in that direction as well. It changed me. It changed my focus and commitment to doing this and developing this project as a way to engage youth. So exhibits can be big. They're totally celebratory. Everywhere we are, the kids get free hot dogs, free admission to museums. We often bring parents together to talk about what kind of work is exhibited. You can see Mark's piece here on the far right. And very informal, where at the end of the project they cut it up and take it home. And they take it with them because it's not mine. It's really the kids' work and their background. So this really just wanted to share that it was really during the program here that I was really challenged by Dr. Geyer to think about not just this sort of loosey-goosey way to do it, but how to think about developing it as a structured process and try to document it a bit more rigorously. And so that led to the development of 2 projects back-to-back of how to really systematize the project and how to think about how to use the findings even before you start the project, and about my interest in development very purely in community-based participatory research and how to integrate community expertise into the research process. And certainly also helped me as a mentor find ways to work with faculty here like Dr. Ocampo, who also changed my context in thinking about how neighborhood affects health outcomes, and to think about participatory research along this spectrum. There's no right or wrong, because I was still, I'm still an artist, right? So I'm still an artist training, trying to figure out where I fit, and I'm creating kind of a new path in some ways. So having that support was really important. I think as community-based participatory research is this full partnership approach, which is some of the work that I'm engaged in and really interested in supporting how to work with young people. We've talked about some health topics and so far, but clearly disparities in health persist, particularly for young people, particularly for adolescents, in an area that I'm uniquely focused on, which is in violence. We need to understand kids' voices and we need to understand their expertise, not only just in terms of informing the research and intervention development, but how do we tailor those to unique community capacities and unique community aspects. And so this is pretty exciting. We just published our first peer-reviewed journal article using this approach, and a press release from the University of Pittsburgh led to 35 other sites posting it on theirs, and an opportunity to really expand this discussion. But as I was driving up, it really started with sort of those cups of coffee and to try to think about how to apply this work. I'm just going to quickly share, because we're supposed to talk about some research background too, about how this led to some core research findings, because I've really kept that dedication and support to figure out how to best translate this process and how to develop it in a way that can be disseminated. So we worked with kids in Pittsburgh and in Baltimore, similar age groups. This wasn't a grand plan, much like the project, but we found that once we did the project in 2 sites on very similar themes, that the kids shared almost remarkably the same types of topics, just based on the same trigger questions. We pushed the project a little bit further to find a way to really incorporate their expertise in their paintings. So we code their paintings, and so you can see here, much like quantitative data, where we would code the text, systematize it in the way that we would do it in a rigorous manner. We've now trying to find new ways to use their paintings and drawings to do that as well, to both triangulate what we're learning, but then also illustrate the kind of expertise that the kids are sharing. And we could never do that kind of work unless we sit down with the kids and code the data with them as well. Do we get it right? Do we get it wrong? And have them share their feedback as well. So these are some of the kids in Pittsburgh that we worked with and some of the other faculty that were involved. And just to share with you how remarkably similar, we learned all about the role of social networks in communities and how kids see, these are very dangerous. Police would, have warned us not to work in certain neighborhoods, and kids talking about how safe they felt in many capacities because people were always watching, and how much their family meant to them and how dear those relationships were, a way to highlight the capacity within neighborhoods, in addition to just a gorgeous eyeball, a gorgeous painting to illustrate that. So it's very different than if I ask, tell me about social networks in your neighborhood, versus if I ask, tell me about your community. What are the things you love and don't love about the neighborhood? That's really coming from a very pure place, especially as we see it across context. Sure, abandoned houses are bad, but it's pretty powerful when 3 kids will sit and paint one painting for 2 days and talk throughout that session about how that vacant house impacts their life. Not only structurally because they're exposed to needles and broken steps and people gather there and it's dangerous, but how that makes them feel about themselves and their peers was a really powerful perspective. Integrating policy makers into this process is key. One of the quotes I haven't heard is that Dr. Geyer always says that there's no public health without politics or budgets. And so how to think about that. So integrating policymakers into even the analysis of the work or the discussions that we have around critiquing has also been very powerful. And then when we ask kids about what they feel are safe or not safe about their neighborhood, again, these are groups of kids discussing their work. We can learn about very specific things about the community. We often have involved adults, actually in every session when we report out. So it's pretty powerful when a young person shares this about their community and the adults say, yeah, that's pretty accurate. But again, not a negative piece about many very challenging things in their community, but them able to share some really, we need a change, we can make this change, and how do we get to that? So the kids are involved in the development of the exhibit itself. Again, what we've learned throughout and what I learned here and from Dr. Geyer about how to keep this true to the community and true to the participants. So they'd love to have me move around on the ground and build the exhibit and design it in certain ways. And the kids participate in disseminating these findings. So even before we start, where do we want to share it? So these are 2 of the kids actually came and presented the findings at the Graduate School of Public Health. But how does that really make a difference? So what factor? Well, we needed to share this in the community as well. So I was elected to present the findings to the police department, to the resident council president, to the public housing authority, because you can imagine the kids were pretty critical. So for me to say, well, they feel that this organization is racist, and they feel that actually you as the chief of police are racist because you act this way. And these are not random findings. These are consistent findings that the kids shared. Well, the chief of police, who's on the back left, was so overwhelmed by the willingness from them to share. And then the kids were, originally, they had wanted to participate in this, but for obvious reasons, it maybe wasn't safe for them to share those beliefs. But she was so, wanted to be involved, now takes off her uniform and participates in this asthma prevention project as an advisor to that project, because she had never seen the community and the capacity of the kids in that neighborhood, and has truly changed their relationship. I do have to be honest and say that one of the unintended consequences of this presentation was an early curfew in the neighborhood, which the adults were thrilled about. Police were thrilled about, kids not so happy about. But it certainly did help with some of the safety issues, so I heard about that. So always being accountable. Just wanted to just quickly wrap up and share that it was this project, if we think about me doing this early before my public health training and background, I used to barter for paper, barter for paint from different art stores, to really thinking about this as a systematic way that we all can use to engage youth expertise, started with those cups of coffee. It started with the inspiration that Dr. Geyer let me feel confident in following, and the support that I felt in an institution and faculty here as well. This has provided an opportunity not only to develop a rich sense of understanding and expertise in communities, but to really lay the groundwork for other projects in Pittsburgh, 2 clinical research studies that have developed. But I think because they got to know us and faculty in a different way than maybe they normally get to know us as well. So where did it start? It started really with the thoughtful and caring mentorship, really critical feedback, really hard questions. Well, why aren't you going to medical school? You know, why are you even here now? Do you really need a doctorate? Where do you want to sit at the table to impact this change? And making me really think critically about those questions and always pushing me to provide honest feedback. And the other thing that Dr. Geyer and Dr. Campo also have always done is ask me about my family and my friends and my community, and the things I care most passionately about. So I wanted to share him a new picture with my kids. And just thank you so much for the opportunity to share this background. My trajectory would never be here today if it wasn't for Dr. Geyer's support and willingness to support me in the program. So thank you very much.
Thanks, Michael. And for anyone who didn't have the opportunity to see the murals in Hampton House, they were truly impressive. Our next speaker we'd like to welcome back is Ann Wallace, and Ann reminds us of Bernie's focus and understanding about how our roots inform where we are today. Ann's a PhD graduate of the department from 2003, and one of the notable things among many that Ann did when she was here was help construct the history of the MCH department here in the School of Public Health. She's currently an assistant professor in the Department of Epidemiology at the College of Public Health at the University of Iowa. Welcome.
I do not have slides. I've been making it a challenge, a personal challenge, to speak without PowerPoints in the last couple of years. So we'll see how that goes. I'm really amazed to be here and so pleased to have been invited. And as I'm listening to colleagues and other former students, it's just clear what a continuum. We're echoing each other, and there's a continual sort of step-by-step growth. And I think it's come from Hopkins, it's come from this department, it's come from Dr. Geyer, it's come from our other mentors and instructors in the department. And it's a really powerful sense. I wanted to talk a little bit about the history of the department and maybe think about what and where Dr. Geyer's role has been and will continue. So in 1997, the Department of Maternal and Child Health, and I should note I'm the last actual graduate of maternal and child health, took a look back on the past 50 years of MCH at Hopkins and in Maryland. So more than 10 years later, on the occasion of Dr. Geyer's retirement, it seemed like a good time to reflect on our history at Hopkins and collectively as a field. So 10 years ago, when we set out, or 13 years ago, when we set out to look at the department's history, we struggled with questions of history and historiography. That is, not just events, but how we think about history. History is more than just chronology, and history is more than just a biography or a series of biographies about individuals. History can be thought of as a collective and continuous understanding of changes and evolution in our intellectual and popular culture. We might like to choose an event or a person or an institution as a crucible through which we can dissect and better understand our experiences. And so in 1997, we chose to examine history and historical process through the crucible or the lens of maternal and child health at Hopkins and in Maryland after 50 and 75 years, respectively. What seemed important to us was the view that history is a collective social epistemology, parallel in a sense to our view of population health as being larger and having more potential impact than treatment of individuals or the isolation of specific diseases or risk factors. We integrate the social into public health and the developmental, geographical, and demographic into epidemiology. As several people have already noted, Dr. Geyer has a gift for thinking in the collective. And by that I mean he has an ability to push back the leaves, remove the undergrowth, scrape away the bracken, and truly see the forest. He has been a teacher, a policymaker, a scientist, and a clinician. He taught us that careers are longitudinal and integrative. That is, you don't have to do just one thing. You need not have just one role, but rather you can take on different roles over time, pursuing, developing, and excelling at a variety of subject matters and tasks. Maternal and child health is also longitudinal and integrative. It has an incredible history where the players are comprised of academics, policymakers, physicians, health department workers, and volunteers who team up to combat the health concerns of women and children. In the US, this tradition dates back to the women of Hull House, to the beginning of the Children's Bureau and the leadership of Martha May Elliott and Ethel Dunham, the start of the Shepherd-Towner Act, and eventually Title V. And in 1947, the inauguration of a maternal and child health program at Hopkins. The department at Hopkins, no matter what its name, began as the single course in child development, taught by Mason Knox and later by Myron Wegman, Paul Harper, Don Cornley, Bernie Geyer, and Dr. Robert Bloom. Over the years, it became the core course in maternal and child health, following a human growth and development template. The course gave students an overview of the thinking of the department, a blend of reproductive epidemiology, developmental psychology, child and adolescent health and development, injury prevention, and global health. The structure presaged a population and social theory approach based on a developmental framework. And this way of thinking about maternal and child health led to new scholarship on infant health in neighborhoods, innovative methodologies that integrate geography with social epidemiology, anthropology, art, the list goes on. Dr. Geyer's contributions are many. He encouraged us to turn old adages on their heads and re-explore public health problems. Is poor vaccination coverage really the fault of mothers not educated or not able to bring their children in on time for shots? Or is it really about missed opportunities, about a failed infrastructure that does not always pay for vaccines, a fractured public transportation system that effectively denies access to care even when coverage exists, or clinicians who don't always understand counterindications to immunization? At a time when public health was patting itself on the back for increasing immunization coverage, it was Dr. Geyer who noted that even a high national rate masks pockets of low rates in inner cities, on Indian reservations, and poor rural communities. Teachers, like Dr. Geyer, reflect their own teachers and their own mentors. In turn, we mirror our teachers, integrating and augmenting along the way. In the Department of Maternal and Child Health at Hopkins, we came to understand the shaping of Head Start, WIC, and Medicaid from innovators like David Page, who forged those policies. We learned to stand up and question received wisdom from Donna Sturbino. Janet DiPietro showed us that we can question and thus refine our understanding of the effects of drugs on the fetus and of breastfeeding on human development, on infant development. Pat Ocampo saw that it would take more than just prenatal care to improve infant health outcomes. And importantly, she discovered methodologically sound ways of measuring those outcomes and their potential causes. Cynthia Minkowitz and the Whole Healthy Steps project brought some very serious innovation, I think, to how we think about evaluating large multi-site public health programs. And I was just really literally thinking about that in the past 2 weeks as I was writing a grant to evaluate a large multi-site teenage pregnancy prevention program for the state of Iowa. So how do you look at many different programs and somehow pull all that data and all that knowledge together into something that we can learn from, that we can find out if there is evidence for a program working, if it does indeed prevent teenage pregnancy, who it works for, who it doesn't. And so I cited the Healthy Steps evaluation model as a potential methodology for looking at these different groups of practices. When I was at Hopkins, I attended, as many of us did, a couple of brown bag lunchtime discussions with Dr. Myron Wegman, in which Dr. Geyer acted as sort of the talk show host, leading with questions and letting Dr. Wegman wax knowledgeably about past and current issues of child health. Dr. Wegman often explained how some of the origins of modern public health began during the Franco-Prussian War, which seems completely just sort of illogical. However, the French, he noted, understood that a strong army required healthy young men, and healthy young men grew from healthy mothers and clean milk. So milk stations providing hygienic milk took off in Paris, in France, and not too much later in New York and later in Maryland and other states. So at the turn of the last century, nearly 1 in 5 children died in their first year of life, and more than a fourth died before their 5th birthday. Then death was attributable mainly to infectious diseases, diarrheal diseases due to poor milk supplies, poor water supplies, as well as pertussis, measles, mumps, rubella. In 1913, the Children's Bureau was established, and in 1916, as we know, a School of Public Health was established in Baltimore. When I asked Grace Bigelow and Donna a little bit about what I should talk about, I was also encouraged to talk about what I'm doing. And I don't have such beautiful slides as you all have presented about your work. I'm going to just give you more of a quick overview. I've been at the University of Iowa for an amazing 7 years, and this is amazing for somebody from the East Coast who went out on the interview really as a, I should be embarrassed to say, a practice interview. And I loved it. And my family loved it. And I've had another child there, and we really have very little intent of leaving in the near future. It's been a very good collaborative environment. I work closely with Audrey Saftlis, who is also a colleague of Donna Sturbino's and a graduate of the Department of Epidemiology here at Hopkins. And we've worked together on studying risk factors for preeclampsia and preterm delivery. And she and I work together with Corina Peak-Asa, where we're studying prevalence and risk markers for intimate partner violence among women seeking abortion. And we're currently testing a brief intervention. I've also branched into, I've just developed a huge enthusiasm for global work. And I've spent the past 5 or 6 years working with Clay Dungy, who I was referred to via Cynthia Minkowitz, working with breastfeeding knowledge and attitudes. And that took Dr. Dungy and I to Romania, where we did a study of breastfeeding knowledge and attitudes and found some very interesting things. You know, for example, there are very high breastfeeding initiation rates, but very sort of negative or at least neutral attitudes and knowledge about breastfeeding. In the US, when you see negative attitudes and knowledge, you see lower rates of breastfeeding. So we were seeing this completely sort of flipped data. And what we think it tells us is that right now in the post-communist era, where the economic situation is very difficult in Romania for families, there's no choice but to breastfeed. So 90%, 95% of women initiate breastfeeding in the hospital. But the first chance they get when they get home is they go to their family doctor and request a prescription for formula, which they can then get for free. And our big concern is that this high rate of breastfeeding initiation will drop off as soon as women have more money and more freedom to do what they think those of us in the more developed countries do, which is use formula. So it's kind of a mirroring, in a way, of what we saw in terms of breastfeeding rates between the 50s, 60s, and 70s, and more of what we see now, just reversed and maybe reversed and slowed down in time, in a sense. So I think it's a precipice, and I think it's one that we have the potential to stop. I've also just concluded, I work with the Injury Prevention Research Center at Iowa and was funded to do a study of injury among Roma children living in Romania in very, very poor conditions. And we did a field survey in a community where we documented mainly housing conditions and community conditions and risk for serious injury. And we'll be continuing that in a couple of weeks when I go to Romania, and partly through a conference and some more field work. I've also developed a significant interest in the reproductive, let me finish with the global stuff. This last December and January, I had the amazing opportunity to do teach a global course in India, in southern India. So I took a group of 13 students, undergraduates and graduate students, all women, ranging from 18 years old to one who was close to my age, so late 40s. And the idea was to study and learn about maternal and child health in southern India. And what it really became in many ways was a fieldwork course. So we visited villages, we visited neighborhoods, including Sri Lankan refugee neighborhoods, and we did any number of different projects that the students chose, with the idea that this would be service learning, it would be developing fieldwork techniques, and that we wanted to, in every case, leave something behind us that would be useful for the village or for the group. So it could have been a teaching curriculum for children about hand washing, or public health messaging about boiling water. There were any number of little projects. We did group interviews, we did geographic mapping, where we had groups of women sit in a circle with a huge piece of paper and just chalk and map out their village and show us where they thought that there was risk for chikungunya and malaria. Through that, we gained just a lot of insight about how they think about place and time and space and health. And I think I'm very, very interested in going back and learning more about the culture of reproduction and pregnancy in South India, and what that means in turn for infant health, but perhaps even more for maternal mortality and women's health. So finally, I've also developed an interest in the reproductive health effects of living in rural poverty. I think we've given a lot of thought, people like Pat and others, to the effects of living in urban poverty, and we haven't done as good a job of describing what rural poverty is And does it confer the same types of negative effects that urban poverty appears to confer? And so with that, I think I'll wrap up. But, I feel so excited to be here, and there's an excitement that comes with being in a group of people like this, and an enthusiasm that's absolutely infectious. And thank you, all of you, and especially Dr. Geyer.
Thank you, Anne, and thank you for reminding us of the global impact that Bernie has had. And I'm delighted to introduce the next speaker, who I have not seen in many years, and it's great to see you, Sam. Sam Forjo. He's a graduate of the Department of Maternal and Child Health. Actually, I think most of the speakers that are graduates, except for Pat, that are going to be presenting for the rest of the day are actually graduates of maternal and child health. And Sam's focus really reflects Bernie's strong interest in injuries and injury prevention. And while Sam was here, he encouraged him to do work in Ghana. And he strongly encouraged him to do population-based work in Ghana, and in particular to do both a census of burns among children in Ghana, as well as to look at the risk factors related to burns in Ghana, and was also very helpful in Sam securing funds for that particular research. Sam is now at Texas A&M, where he's a professor, and he's director of research for community health in the School of Medicine. And I think he's probably going to tell us about some of his work that he's still doing in injury, but I'm not exactly sure. So welcome, Sam.
Well, as you can see, I have several name tags. It shows how the legacy I got from Bernie. I've been busy. This morning I was at HRQ grant review session, and I had to run to make a presentation at a conference in Bethesda, so from Rockville to Bethesda to Johns Hopkins. That was why I was late. And what I want to do is to give you a sense of what I've gotten from this man sitting there. I mean, he's had so much influence in my academic career. I don't know how to thank him. And I'm going to talk about reflections and how I'm trying to reinvest myself in Ghana. Because since I saw him in 1990, he's been wanting me to go back to Ghana. The page down. When I hear his name, I think about several things. First, as a colleague, because he's a doctor, I'm a doctor. When I met him, he became a facilitator, and then he became a father. You can't believe it, but when I left Harvard to come to Hopkins, I spent the first weekend with him, with my family. He became my advisor, and then the teacher. I took his course. And then he employed me, so I became his boss. And then he supervised my doctoral thesis. He actually followed me to Ghana. And he's become a mentor since he became a co-author with me. And 10 years ago, I became a citizen, so he became a fellow countryman. And he's been an inspirator for me. I mean, words can't describe. And finally, he's been a role model for me. I just want to chronicle the milestone contacts I've had with Bernie. I first met him in 1990 when I was taking a course in environmental health at Harvard. And believe me, the first time I saw him, I didn't think he was friendly because he was busy preparing to come to Hopkins. So I had to write a paper. And as a physician trained in Ghana, I'd never written a line in my life. So I went to him, and he was supposed to guide me and say, what is this? What is that? Well, I didn't know you had to tell him if you didn't know something. So I said, I was trying to think I knew, and he put me off. But later, I went back to him. And I found him to be the most pleasant, useful person in my life. After my MPH, he was coming down to Hopkins, and he encouraged me to come and continue my studies. So I joined him here in the department, and obviously became an advisor to me. And that is when he started having a big impact in my life. In 1992, when I went to Ghana to collect my data for my thesis, he actually followed me to Ghana to make sure I was doing the right thing. Luckily, we were funded by the Rockefeller Foundation, so he didn't have to dip into his pocket. And coincidentally, 2005, when I was in Ghana celebrating my 50th birthday, Bernie was in Ghana, and he was about to leave for Togo, I think, and I told him, Bernie, I'm celebrating my 50th birthday. He said, no, I'm coming. And I mean, he was gracious enough to come and grace the occasion. And today, I'm here testifying to what impact he has had in my life. I just wanted to show a few things. I don't have any academic stuff to present. This was taken in, I think, May of 1994, because he had some bushy hair. And you can see Bernie and members of my dissertation committee. And Gordon Smith is the only one who is not here. And as Donna alluded to, I focus on injury, but I've had so many turns in my career. Right now, I'm a professor of family and community medicine. I'm doing several things because of the impact Bernie gave me. I mean, I concentrate in biostatistics at Harvard and did epidemiology here, so I can pretty much do a lot. But this shows not only Bernie, but others, including Donna Strobino, who steered me to where I am now. And one thing I learned from Bernie was, he told me, whenever you do a piece of work, try and present it and continue to publish it. So from my doctoral thesis, we were able to present 4 abstracts at various conferences. I had never made a presentation before, and Bernie encouraged me to submit the first abstract to the World Conference on Injury in Atlanta. This was as far back as 1993, and it has continued. And believe you me, through his inspiration, we were able to publish 8 manuscripts from my doctoral thesis. And he was a co-author in about maybe 6 of them, including Donna Strobino. And I owe this to him. And because of this sense of wanting to do more that he gave me, I've continued to flourish in academia. He never stopped. In 2000, I was in Texas and had a call, or I think an email. Sam, I'm invited to do an editorial for the British Medical Journal. And because of the confidence and the sense of responsibility he had in me, he invited me to co-author this with him, and we did a good job writing this editorial. I couldn't have done this without him. He didn't stop there. I mean, he showed me how to write monographs, and I know I haven't written a book in my life, but through his inspiration, I've been able to contribute to several book chapters, basically on injuries and on other things I didn't want to show, because his focus was on injury, as far as I know. All said and done, Dr. Gaia has always wanted me to go back to Ghana. I mean, and so after some time, I've been thinking about how I can reinvest myself in Ghana. And I think 4 years ago, I began thinking about how I'm going to go to Ghana. And so I said, why do I want to go to Ghana? Of course, Ghana still needs help, and I've put down some statistics. And there's always the need to give back to what you have obtained. I mean, I had free medical education from Ghana, which is like $200,000. I had it for free, so I think there's a need to give back to Ghana. And luckily, I've been able to build a home in Ghana, so I know I can retire in Ghana. For the benefit of those who don't, I have dual citizenship. I'm a Ghanaian and a US citizen. So these are the compelling reasons why I'm thinking about reinvesting in Ghana. Just to show you a bit about Ghana, for those who may not know, Ghana is just a small country like Oregon, with a population of 22 million. By the way, we won the first match in the World Cup. These are some of the top reasons. Because when I want to go when I get ready to go to Ghana, I want to still be able to see patients because I'm still licensed to work in Ghana. So I'm still reflecting, can I still be efficient and effective when I go back to Ghana? But I think these are the top 10 reasons to go to Ghana. Luckily, they are not real like Alzheimer's or cardiovascular, but simple things that we can see and treat. The other weird problems in Ghana, the last few years that I've been visiting Ghana, including typhoid, of course, HIV is huge in Ghana. This shows Bernie's passion. These pictures were taken by me when I had to consult for the WHO on the burn project with Andrea Gillan, who is here. And so I went to Ghana to do some studies and saw these pictures that I wanted to share with you and Bernie. This shows some of the weird things in Ghana that people here don't think about. Shows how people are still suffering with cancer, skin infections, and results of alcoholism and hepatitis, given ascites. And one other thing that is happening in Ghana that people don't know is the population is aging. It's aging very much. This is my mother who died 5 years ago, and she died at 80 years. I still have an aunt who is 85. And so when you hear about the life expectancy at birth as stated at 60, you think most of us die before 60 years. No, I think I'm going to live to 90 or more. So as I think about Ghana, I think about what I can give back to Ghana. And so I have the elderly at the back of my mind when I think about reinvesting in Ghana. This shows the hospital that I worked in Ghana as a medical student. You know, it's not the best of hospitals, but with time it's changing. And now we have nice facilities with almost everything that we have in this country. But I took this picture, I think 2 years ago when I was in Ghana, and I was amazed at what I saw. Whereas when I was in Ghana, we couldn't treat burns covering 10% body surface now. This woman had, I think, 90% burns, and she was saved by the facilities we have in Ghana now. So how am I reinvesting myself in Ghana? I started slowly because I'm still young and I want to do this in a gradual process. So what I started was 5 years ago. I started a medical student elective program where I'm taking students to Ghana, and it's a way of giving back. So I take students every year in the summer to Ghana, and I take them to the hospital that I worked at, and so they offer services to Ghana, and they also get some useful knowledge. The second thing I'm doing is there's a program called African Partners Medical CME Conferences. There's a group of physicians, not only from Ghana, there are about 50 of us. We go to Ghana every September, and we offer free CME services to the physicians, not only in Ghana, but in the rest of Africa. Last year, I think we have about 150 participants. They pay a token fee, and so anybody here can go. If you're interested, you choose a topic that you want to go and talk about, or a procedure you want to show the physicians in Ghana. And so you go every September, you spend like four days in Ghana. And then I'm beginning to build a hospital with a focus on geriatrics and public health. And so I'm hoping in the next 5 to 10 years, have this completed. And even though I'm not going to move to Ghana immediately, I have plans to go back. But I think it's a way of giving back to Ghana. So this picture shows some of the medical students I've taken to Ghana in previous years. Unfortunately, these were students from the Florida State University School of Medicine. And this was an interesting story. They were initially planning to go to Nigeria. This was 4 or 5 years ago. And I guess at that time, it wasn't very safe to go to Nigeria. So they were looking for somewhere to go. And luckily, somebody mentioned me. And so I took them to Ghana. And they had a wonderful experience. And subsequently, I've been taking students to Ghana, and I've even developed a course, which is an elective course in the medical school, called Ghana Medical Elective. And this shows a snapshot of what we did last year, the CME course I've been talking about. Like I said, last year there were about 50 faculty from North America, including I think 20 Ghanaians and 30 Americans, including nurses, therapists, health educators, anybody who feels like contributing their time to go and offer their services together. And finally, this is the hospital I'm beginning to build. And what I would like to do is make this paperless, digital, wireless, and make it as modern as possible. We'll focus on primary care, preventive services, emphasis of maternal and child health, and geriatrics. And I think I couldn't have done all this without the knowledge and inspiration I've got from Bernie Gaia. For this, I'm very grateful, and I'm happy to be here to testify to what he has done for not only me, but for several of us here. So I wish you luck in your retirement, Bernie. And finally, when I came here in 1990, I was here with my wife and 2 kids. They were little kids, I'm sure, because she's Donna, they met them. Sheila, the middle one, was 3 years at that time, and I used to go to the computer classroom with her. Now she's a law student at UT after graduating from Washington University in St. Louis. Harriet, the older one, just completed nurse anesthesiology course, and she's working for Johns Hopkins. So it's a way of giving back to Hopkins too. And they all join me in thanking you so much for what you have done for us. Thank you so much.
As Bob said at the beginning of the afternoon, much of what Bernie has done is also strike a balance, and no afternoon celebrating as many accomplishments would be complete without including some of his family who are delighted are here today. And our next speaker is going to be Sam Geyer. Sam is Bernie and Jane's oldest son, and he's currently an assistant professor in the Department of Computer Science at Tufts.
So, well, you'll be happy to know that this presentation is I think only 9 slides. I'll just tell you that right at the beginning, so you can count down. So I'm really one of Dr. Geyer's first students, first collaborators. I'm actually a computer scientist, and I pondered giving you a long talk on mathematics, but I didn't think that would go over all that well here. We have over 40 years of collaborative work, for just a little bit over 40. And it covers a very surprising range of topics. You'll find none of the projects here are about maternal and child health, although I believe some of them involved real-life childhood injuries. But I don't remember exactly. So today, just highlights of our results. This is not a comprehensive review of our literature. I thought of a dozen more good ones just on the way over here, but also just a brief caveat. This was developed under the influence of heavy-duty cold medication, and so it's full of errors, misrepresentations, inside jokes, and probably outright lies. All right, so projects. All right. Yeah. Oh, gosh, these research methods. Oh, highly unorthodox. I don't think a single IRB was obtained for anything. All right. So, early project. So this was a long time ago. So the question here was, is the medical school experience realistic enough? All right. So, experimental setup. So we took a real medical student and his wife, both new parents, and subjected them to terrifying real-life medical emergencies. I played the main subject as a 1.5-year-old. I presented unexplained vomiting and an inability to eat for I don't know how long, a long time. The outcome actually was quite positive, which was good. Full recovery of all functioning. Although my father never really became a practicing pediatrician, so I don't know. You be the judge. Secondary outcome, inside joke for the family there. All right, so that was an early project. So this was a popular, also ongoing project. So again, the diversity of research here. So our material science work was really focused on household tools. So what we did is we took household tools, planted them in the environment, left them for some extended period of time. Measurements included the rate of loss of tools, did they function, how angry did my father become when he couldn't find them. We found rates roughly proportional, I think, which was the expected outcome. That's good. I don't know. Possible future karmic payback. My son is already very interested in tools, and I think I could be in big trouble there. Right, so then, surprisingly, quantum physics. Who would have thought, right? So, bear with me here. So, here was the experimental setup for this. So, this involved my father upstairs trying to get work done. So, us as assistants would come and pester him relentlessly while he's trying to do work. And so his proposed experiment was, hey, why don't you go down to the basement and see if I'm there? Now, hold on. This quantum mechanics actually allows this. This could happen. Wave functions and quantum entanglement. Things I don't understand very well. The outcome, he wasn't there, and hey, wait a second, I think you tried to fool us. All right. So, please, if you have any questions, keep them to yourself. Okay, so food science. So let me tell you a little bit about our food. So, here was the experimental setup for this. My mother went away for 2 months on field work, and so the available materials for this experiment were meat, beans, and cheese. And the question was, how many days in a row can you eat burritos? Measurements included whining / complaining. Naturally, for this one, we need a graph. So, interest in burritos peaked very quickly and dropped off extremely steeply. I don't know what happened. Somewhere here, someone suddenly decided they were okay again briefly. I guess the good news is I still like burritos and appreciate food and cooking, thanks to my parents. And finally, this was one of our longitudinal studies. So the experimental setup here was I played the primary PI, and my father played the co-PI, mainly because he could drive. And it involved, over a period of many years, repeatedly dragging him to old abandoned mines and quarries to look for rocks and minerals. Results of this long-term study were a very large collection of rocks in the basement. Sorry about that. I swear one of these days I'll get it and take it with me. Secondary, much gratitude for indulging my interests, my scientific interests. So, I guess summary, lessons learned from my father. Work on problems you care about. That's something that stuck with me. Always be generous with your co-authors and collaborators. And I think you all have probably felt that. Balance work and home life. Do all of those things. Start working on things early. Now, oh well. I guess you can't get all of them, but thanks. Someone up next.
What about garbage collection?
Yeah. Oh, you want to hear it? I have a whole presentation about my research.
Thanks, Sam.
Thank you.
Thank you, Sam. And are we ready with the call-in? Yes. Great. Wow. So we have a special call-in. Xiaobin Wang, who's a graduate of the Department of Maternal and Child Health in 1991, was unable to be with us today for some unfortunate reasons. She's fine, though. So she's going to join us by phone, and there she is. And what I think is noticeable about Xiaobin is that she reflects Bernie's real strong commitment to looking at the integration of biology in research and in maternal and child health. While she was here, she worked with Bernie on several projects, including looking at Asian infant mortality as well as low birth weight and birth weight among Asian, particularly Chinese and Japanese women. And I think that she's probably going to talk about some of the research she's been doing recently on the gene-environment interaction in relation to pregnancy outcomes, although I'm not sure she is. And for some of the students who've recently taken comprehensive exams, they'll probably remember the name of Wang on one of their questions, and she was the author. So we're delighted to have Xiaobin join us.
Donna, thank you so much. Good afternoon, everyone. I wish I could be with you on a special occasion, but I'm so delighted I can at least talk with you on the phone. For those we haven't met, I was Bernie's doctoral student here at Johns Hopkins 20 years ago. What extraordinary about Bernie is that he's not only my most respected leader and a role model in the maternal child health field, but also he's always there to provide me the support and the guidance at the critical points of my career. It is impossible to tell you all about Bernie in a short time. Today, I will just share one story with you. Like all the students, I was struggling to figure out what I could do for my doctoral thesis. Thanks to Bernie's vision and advice, I chose the field of perinatal epidemiology, with a particular focus on infant mortality and ethnic disparity. I was also fortunate to have a wonderful thesis committee which consists of Bernie, Dr. Donna Strobino, David Page, and Sam Shapiro. I was so excited that 2 papers from my thesis got published, one in AJE and another in International Journal of Epidemiology. I must say, my doctoral training at Johns Hopkins has laid a solid foundation for my later academic career, both in terms of the research methodology and the practical experience. Remarkably, the challenge I was trying to address 20 years ago has remained a major clinical and a public health challenge today. For example, despite impressive scientific and clinical progress, preterm birth and infant mortality continue to be high in the U.S., in particularly in Black populations. This is the most recent release of the U.S. top 10 leading causes of neonatal death. As you noted, disorders related to short gestation and low birth weight are the #1 cause of neonatal death, accounting for a quarter of neonatal deaths, but in blacks it counts for 1/3 of neonatal deaths. An important milestone in my career was to join the Boston Medical Center. Thanks to Bernie's strong recommendation and a connection, I met with Dr. Barry Zuckerman, who was the chairman of the Department of Pediatrics at the Boston Medical Center. I couldn't believe that I was not only accepted into pediatric residency program, but also appointed as research faculty at the same time. That marked my 10-year clinical and research career at the Boston Medical Center. I remembered vividly my first pediatric rotation was started at a neonatal intensive care unit. I witnessed the first time the tremendous impact of prematurity on the babies and their families. As you may know, preterm birth presently affects about 1 in 8 births in the United States. Preterm babies are at a great risk for neonatal mortality and morbidity, and also have a severe long-term consequences that include cerebral palsy, chronic lung disease, blindness, deafness, and learning disorders. My clinical experience at a neonatal intensive care made me firmly committed to preterm research, which has continued today. As a junior investigator, I was hoping to identify an area that I could make important and a unique contribution to the field. After review of available literature, I directed my attention to a largely unexplored area at that time. That is, what is the role of genetic susceptibility and gene-environment interactions in preterm birth? For those who are familiar with preterm birth research, up until recently, we knew very little about genetics and gene-environment interactions in preterm birth. The first question I asked was, does genetic factor plays a role in preterm birth? I was certainly very encouraged when our work was published in the New England Journal of Medicine. Our study demonstrated a strong familial aggregation of low birth weight and preterm birth, which may be attributable to shared environmental factors, genetic factors, or both. This study set the stage for our subsequent effort to incorporate genetic susceptibility and a gene-environment interaction in preterm birth research. My next challenge was trying to design and conduct a genetic study of preterm birth. To do so, we needed to establish a large birth cohort that is specifically designed for molecular and genetic epidemiology study of preterm birth. This was certainly not a trivial task. We initiated a Boston birth cohort with a small seed grant first from our department. Over the past 10 years, we received subsequent support from NIH, March Dime, as well as philanthropy funds. So we're able to grow this cohort into one of the largest cohorts of this kind in the United States. So at present, the Boston birth cohort has enrolled over 6,400 mother-infant pairs, and with majority of Black mothers, and also with substantial numbers of Hispanics, and with over 2,000 preterm births in the cohort. So this is not only is a birth cohort, also is a longitudinal cohort. So we enroll the babies at a birth with a collection of epidemiological data, perinatal and prenatal clinical data, as well as establishment of large biospecimen repositories, which has proved to be valuable not only for the current research and also will going to be continue to be valuable for the future research. This cohort also being followed postnatally and with collection of both clinical epidemiological data, lung function testing, total and specific IgE testing, as well as blood sample collection. I'm going to move to the next slide. In the following, I'm going to just give you a few examples of the work conducted within the Boston birth cohort. The first example is the large-scale candidate gene studies. Within the limitation of the funding and the technology at the time, our team conducted still by far the largest candidate gene study of preterm birth. We analyzed 25 genes along the major pathogenic pathway of preterm birth. We identified several promising candidate genes and SNPs, and of which factor V gene is the most significant, and in fact, were able to replicate in a later study. Next slide. Another example I'd like to share with you is our gene-environmental interaction studies. This is one of the examples of gene-environment interaction we found in preterm birth. As you may know, maternal smoking is a known risk factor of preterm birth, but its health effect varied greatly among individuals. Such individual variability could in part due to the genetic variation. So our study was set to examine if maternal genotypes can modify the association between maternal cigarette smoking and infant birth weight, gestational age, and fetal growth. We focused on two major metabolic genes, C1P1A1 and GSPT1. So this slide, if you look to the right, this slide illustrates how maternal genotypes can interact with cigarette smoking to affect on preterm birth. The y-axis is odds ratio of preterm birth. The x-axis is the study group. If we look at the first bar on the left, without consideration of genotype, as expected, the odds ratio of preterm birth associated with maternal smoking was about 1.8. If we look at the last bar on the right, here we consider the maternal genotype. For mothers with both C1P1A1 and GSPT1 variant genotypes, the odds ratio of preterm birth was over 10. This finding we are able to replicate in our later study. Next slide. So now I'd like to share with you two ongoing studies in the Boston birth cohort. As you know, one of the most remarkable advancements in biomedical research in the recent decades has been human genetics and high-throughput biotechnology. The traditional candidate gene approach has many limitations, as we recognize. Genomic-wide association study, the short term will be GWAS, is now considered the most powerful approach for discovering novel susceptibility genes of complex human diseases, including preterm birth. With the grant support of NICHD, we are conducting a large-scale GWAS of preterm birth with the goal to identify novel genes of preterm birth in a multi-ethnic, high-risk urban U.S. population. This study is still ongoing. What we hope is that this study will lead to identification of novel genetic loci of preterm birth. Such findings may not only provide important insight into the etiology of preterm birth, but also may help identify women at high risk of preterm birth. So another ongoing study, next slide, another ongoing study in the Boston birth cohort is the epigenome-wide association study of preterm birth. This study just recently funded by NICHD. So as you may have heard, epigenome adds an important new dimension to modern epidemiology. Epigenetics is the study of modifications of the DNA or associated proteins other than DNA sequence itself. There are many important features of epigenome. First of all, environmental factors can modify epigenetic states. There are already several good examples of this. For example, folate intake can modify epigenomic state. Epigenome also interacts with genome. That means the gene and the epigenome do interact with each other, which in turn regulate gene expression. Epigenome also changes with age and cell type, and is also inheritable. Although it's not DNA sequence, it is inheritable. Epigenetics may help explain intergenerational effects, gene-environment interactions, and provide new clues to disease prevention and therapy. So with the support of NACD, we're conducting the first epigenomic study of preterm birth in conjunction with genomic-wide association study in African American mother-infant pairs. We hope that this study will help us gain new insight into the causes of preterm birth in a population with high prevalence of social environmental adversities and high rates of preterm birth. So next slide. So when I was a doctoral student at Johns Hopkins, the first Institute of Medicine report on low birth weight preterm birth was released. That was published in 1985. 20 years later, in 2006, I served as a committee member of the second IOM report on preterm birth. If you have a chance to compare the first IOM report versus the second IOM report, you can see that tremendous progress indeed has been made over the 20-year period, in particularly in the area of genomics, proteomics, and biomarkers. Next slide. Going forward, given the complex etiology of preterm birth and the limited success in our past research and intervention, we need a new paradigm for preterm birth research. Our team is working towards this goal. We plan to utilize the extensive database of the Boston birth cohort to simultaneously evaluate the roles of environment, genomics, and epigenomic factors, as well as their interactions in preterm birth. We will also explore the interplay of maternal and fetal genome and epigenome in relation to preterm birth. We are hoping by integrating multi-level and multi-dimensional data, will transform our understanding of preterm birth and develop a new paradigm for prediction, prevention, and treatment of preterm birth. Such effort, in turn, may also help reduce infant mortality, health disparity, and reduce health care costs. Next slide. About 6 years ago, I was at another critical point of my career. Again, thanks to Bernie's encouragement and advice, I accepted a position at Northwestern University Medical School to lead the Smith Child Health Research Program. This position has given me tremendous opportunity and resources to grow and to lead a large interdisciplinary research program. In 2007, 3 years ago, Bernie served as a member of the external review committee of our program, as convened by our medical center. Bernie's evaluation and recommendations has greatly helped our program move toward our goal to become a leading child health research program in the country. Next slide. In closing, it has been a great privilege to have Bernie as our leader, mentor, and a role model. What Bernie has done for the world, for the country, for the school, for the department, and for his students are truly extraordinary. Bernie, I wish you all the best and hope to see you more often in the coming years.
Thank you.
I also want to take this opportunity to thank all my teachers and colleagues at Johns Hopkins. Wherever I go, I always feel extremely proud to be a former student of maternal child health at Johns Hopkins. Thank you all for listening, and you are welcome to visit me in Chicago. And also, just to let you know, summer is the best season. Thank you all.
It's a pleasure to introduce our next speaker. Pat Ocampo embodies so much of what you've heard about Bernie's passion for science, using data, and thinking the big picture for conceptual thinking, as well as what Michael spoke about with regard to working with and in collaboration with communities. Pat's a former faculty member in the Department of Maternal and Child Health, and one of her early projects in her career was actually working on a needs assessment with Bernie for the Baltimore City Healthy Start group, and it's an organization which is still very active in Baltimore, and one that Pat and I had the pleasure of having an ongoing project and working relationship with. Pat's currently the director of the Center for Research on Inner City Health at St. Michael's Hospital in Toronto, where she's also a professor in the School of Public Health. So welcome back.
Thank you. It's a real honor to be here. And it's really very exciting to actually hear about all of the different ways in which Bernie has had an influence on students' lives, on faculty's lives. And it's also great to hear some of the wisdom that he shared with others that I missed out on. So I really feel like I'm benefiting from being here today. Thank you for sharing. I'm going to be talking about a training program, actually, that's going on in the Center for Research on Inner City Health, the center that I direct. Our mission is to reduce health inequities through innovative research that supports social change. And I'm really excited about our training program. And it's kind of odd because when I left Hopkins and I didn't go necessarily to a university setting, I went to a hospital, I thought, oh, shoo, I don't have to teach anymore. But actually what happened is I started these training programs, and they're really great training programs in a way because I don't have some of the same constraints that universities have with the training program, so I have a lot of freedom to apply some of the things that I learned, and definitely some of the things that I learned from Bernie about training. So a little bit about my center. We're a multi- or transdisciplinary team. I have about 17 scientists that are part of the center. We have health economists, ethicists, geographers, sociologists, psychologists, psychiatrists. About a little under half are actually clinical scientists. And the rest of us are social scientists. So we do a combination of clinic research and population-based research. But the idea is that some of the problems that we address are so complex that we really need a transdisciplinary approach to addressing these issues. And the other thing to note about the center is that quite a bit of our work, especially since I got there, has really focused from just documenting problems and demonstrating the magnitude of problems to really moving toward solving the problems. So we do a lot of evaluation work in the area of complex interventions, and we do work in the area of trying to synthesize evidence to inform interventions. So we really are moving away from the problem space toward the solution space. So the training program that I want to talk about is called Achieve, Action for Health Equity Interventions. And it's a training program that really focuses on engaged scholarship. So by engaged scholarship, it's really hands-on, trying to ensure that we prepare our trainees to be educated citizens consistent with democratic values and civic responsibility. We're really addressing some of the critical key questions that are facing society when it comes to inner city health, and really trying to contribute to the public good by trying to identify some solutions to some of the issues facing inner cities. And so it's a postdoctoral training program. The idea is that we want some of the trainees in our program to already have research skills, strong research skills, to be able to apply to some of the issues that they are facing. And it very much is focused on the solution space. So we actually generate evidence together to inform interventions, or we do evaluations together. So the emphasis of the program is about providing solutions, as I just mentioned. The kinds of programs, the kinds of activities that we've taken on have been around the area of equity, for example, developing evidence-informed equity indicators to help hospitals around Ontario address issues of equity, to make sure that there's equity in access and equity in the way care is administered. We also do evidence syntheses, not just any old evidence syntheses, but evidence syntheses that really focus on kind of complex problems. And we also do this in partnership. So one of the key features of the program is that we partner with either policymakers, decision makers, community organizations, community-based service providers, to do team-based research together that focuses on interventions. Again, whether it's generating evidence, a lot of times some of our partners will come to us and say, we're really having trouble with this particular issue. Can you help us generate evidence? Or we have this innovative program and we need to know how to evaluate it. And so what our postdocs do is we form teams and we actually go out and we do the work. And one way we're able to do that is because we have a full year to be able to engage some of our community partners on some of these team projects. So we have time to do the research and also to focus on also not just the research, but on knowledge translation. So not just, for example, dissemination and writing academic papers, although we do that, but also in preparing community reports, which are widely disseminated by the community partners themselves, for example, to other community agencies or to other agencies that are addressing some of those issues. The other thing that we focus on is integrated knowledge translation. And what that means is we partner early on with our community partners or our decision makers so that they help shape the way in which the research is carried out. They help prioritize what some of the research issues will be, and because they're going to be the users of this knowledge that we generate. So we've got 6 years of funding. It's actually our second round. So when I got there, there was a training program in place, actually, and it was one of your, I don't know if it's typical, but it was the kind of training program where postdocs would come and they would kind of bring their research and we'd find them a desk and they would do their research, sometimes in partnership with other faculty, but oftentimes alone. And so I turned that training program into a program that really had more structure, more focus on solutions, and more focus on partnerships. And we have a number of partners around Ontario from, as I mentioned before, community organizations that focus on special populations, for example, Aboriginal populations. We have a number of partnerships with public health agencies, other regions in Ontario like Peel and certainly Toronto Public Health. We have partnerships with the Ministry of Health and Long-Term Care, Canadian Partnerships Against Cancer, and so all of these partners have come to our training table and have gotten involved in helping to identify projects in which our postdocs can participate in. So the fellows in the training program gain exposure to real circumstances and priorities facing our agency partners, They experience how the decisions get made and the role of evidence in those decisions. Because contrary to what we often think, that as long as we generate the evidence, then the policymakers will see the light and then policy will change, policy doesn't happen that way. And there are a variety of situations where, in fact, evidence doesn't really matter at all. But if we engage the policymakers early on, they're more likely to use the evidence. And the partners gain access to research, to people doing research. They also have an opportunity to influence the research agenda, and they've certainly influenced the research agenda that we've taken on at the center. And they have an opportunity to participate in training modules, and they've actually had quite a big influence on the careers of the postdocs who've come through the program. Okay, so what does Bernie have to do with the Achieve training program? You know, you've heard here today that Bernie has a unique way of kind of influencing students and approaching training, and certainly all of those apply. The exposure that I've had while I was at Hopkins, both training with Bernie and jointly teaching courses and giving workshops, et cetera, has very much influenced the ways in which I've approached this training program and designed it. So let me just speak a little bit about that issue. I first want to clarify something, though. Bernie's a great mentor, but he's not a mentor like this. He certainly doesn't encourage people to become just like him. However, recently I have been considering perhaps taking on a new look, and I didn't know what you all thought about this. You know, actually, when I showed this to my colleagues, some of them said, hey, if you do that, you might be able to be CEO of your hospital one day. So I'll consider it, and please tell me what you think after, if you like the look or not. But to be serious then, certainly when I first came to the Department of Maternal and Child Health, one of the great things Bernie did was he took me out into the field. You know, we made great friends with Healthy Start folks. The Healthy Start experience continues to have an impact on my life. And also partnering with other health department folks, that was very, very important. So really kind of going out there and doing research that matters. So taking that experience and really trying to bring it to the Achieve training program has been really fantastic. And the feedback that I get about the Achieve training program is that it really has impacted the students' life. We actually get a lot of people who come to participate in our projects, a lot of students from the University of Toronto who are still in training there, and they actually don't have opportunities to engage in research the way that Achieve promotes research. So we get a lot of volunteer students who participate in our projects. The other thing that Bernie did is that a lot of what we did together is we did case studies together. So we've done infant mortality case studies and evaluation case studies. And in many ways, I learned that case studies were almost like the real thing. They were the real thing. And so what I did is I took the idea of the case studies and I used that as a template for Achieve. And I'm not constrained by having just 8 weeks for a particular course. I have a year. And so that really informed the approach for some of the structured part of the Achieve program to ensure that the trainees got hands-on engaged experience in doing interventions research. So it's a really popular program. We were really surprised. We thought we would just get people from Toronto, but in fact, we've had people from all over the world apply and come to be part of our Achieve program, and we've heard from them that it is really unique, and so we're quite proud of our program. And so in great part, I have Bernie to thank. So I just want to close by saying thank you to Bernie for your inspiration and for your generous and caring way of being a mentor and for your passion to maternal and child health. Thank you very much.
Thank you, Pat. And we now have another Geyer family speaker to entertain us. And I think as you've all learned, there's more than one doctor in the Geyer family. And this doctor is Doctor of Anthropology. She's chair and professor of the Department of Anthropology at Johns Hopkins University. And I suspect that Bernie learned some of his love for Africa from you. And I suspect also that a lot of what Bernie talks about in listening to the voices of the community and the voices of people come from your influence as well. So I'm delighted to introduce Jane Geyer.
So thank you so much for inviting me to speak. And indeed, I did think that I should focus on Africa, focus my 10 minutes on Africa, in part because when Bernie got a Lifetime Achievement Award earlier this year, when I read the citation, I realized that Africa was hardly represented. And indeed, Africa has been not only, of course, a huge part of my own life, but very important also in many decisions that Bernie has made. So I thought that I would try to weave together a focus on Africa and also the expectation I'm sure you have that a wife is going to tell you something that you didn't know already about Bernie. So yes, I'm going to come to Yaoundé in a minute. I'm going to start a little earlier than that. I'm going to start in 1968-69 when Bernie and I went to Nigeria together. Of course, our collaboration is now 45 years, isn't it? About 45 years. You probably don't know that he took out from medical school in order to come to do field work with me, and he had his own project. And it was really out of that project that his very first publications come, I think 1970. His very first publications are about child health in Nigeria from that research. I think, he'll confirm it perhaps, that his interest in public health came out of that experience, that up until that particular moment, Bernie was quite a devoted lab scientist. He loved the lab, he loved biology, and he had a very strong social conscience that you've all mentioned, but the idea that you could put them together into a career in public health really, I think, came to fruition in Nigeria. The other thing that Nigeria really put in place for us was totally accidental, and that is the kind of division of labor between us. Bernie announced what it was around 2 or 3 years into our marriage. We were living in a little flat in Ibadan, and we had a knock on the door, and there were these missionaries at the door. You know, I don't know whether they were Pentecostal in those days or exactly Jehovah's Witnesses, somebody, right, coming to the door. So Bernie opens the door, and they start in to their thing. And he says, wait a minute, wait, stop right there. He said, you're talking to the wrong person. He said, in this family, I deal with this world, my wife deals with the next. And indeed, in some ways, that's the kind of partnership. Bernie is always trying to make things work. I perhaps come up with more than my fair share of the wild ideas. And Bernie has been the one with the eyes on exactly how you make something work, which is what I'm going to talk about for Yaoundé. I'm just going to give one small example with respect to the importance of his work in Africa that's exemplary of that particular quality. So 1976, Bernie was a CDC officer in Yaoundé in charge of the international quarantinable diseases, the surveillance for the international quarantinable diseases for 5 countries of Central Africa. In fact, he thinks that he may be one of the first investigators of the outbreak of Ebola virus when that particular disease came onto the screen. That was his major job there. He was at the very end of the smallpox eradication program, so smallpox was a very important part of his work. But having worked in Tennessee, he was state epidemiologist for Tennessee for 2 years, 1972 to 74. He had worked on childhood immunization, and of course he's a pediatrician by training. He became very interested in child health in Yaoundé and did a survey of measles incidence, and then discovered that not only was the incidence high, but there was no program of immunization. There was really nothing. There had been the French system of campaigns. Every 2-3 years there would be a campaign to immunize. But here was Yaoundé, a growing capital city, a couple of 100,000 people in those days. And that particular system had lapsed. The only way that children were getting immunizations was if their parents went and bought the vaccine from the pharmacy. So Bernie went over to the pharmacy to see what the vaccines were like, and they were not kept with adequate cold chain. So really, this was a very problematic situation. So he, alongside the work that he was sent by the CDC to do, he started in to create a regular, systematic immunization system for the children of Yaoundé. So what did that involve? All kinds of details. So I remember many of them. A lot of them came through our dining room, through our kitchen, through the terrace of our house. He found somebody within the Ministry of Health, Dr. Simon Atangana, who was willing to sponsor this effort to try to do this. And he seated him 10 workers. Bernie tells me that some of those workers were ones that Dr. Atangana was quite pleased to move on to some other activity than his. So Bernie trained these people. They went through the entire logistics of putting together a comprehensive immunization program for Yaoundé. So he had to test the viability of the vaccine, he had to order the vaccine, he had to ensure the cold chain. I remember him saying that he was going to the airport to actually receive the vaccine at the airport when it came. He had to set up schedules, he had to design cards. The whole thing from soup to nuts fell into the workload of that particular team. They had to advertise it. They had to encourage the families to bring their children to this program. There's one incident that I wanted to share with you when we think about missed opportunities. As I've been asking him in the last few days, there are things that I forget, of course, of what he had done. But his paper on missed opportunities with respect to immunization, his first paper comes from Tennessee, from the era of working in Tennessee. And one of his students has since said that this is the first published paper on missed opportunities with respect to childhood immunization. So he was bringing that concern to Yaoundé. So the incident I'm going to tell you is so mundane that you will be surprised, but I think it reflects Bernie's concern with making sure that opportunities are not missed. So let me go forward and tell you something about Yaoundé in 1976. Okay, so now this is the problem. He's given whole courses on problem solving. This is a problem that you've never ever given a course about or a class about, Bernie. But it was a problem that presented itself. Bernie came home from his immunization efforts early on in the program, and he said, "Jane, I faced this real problem today. We had this real problem today." I said, "What was that?" He said, "I was pinned against the wall by a crowd of moms and babies, and I couldn't move." So he said, well, so what was that about? Well, it was about the fact that the clinic was being held in a room that only had one door. So that's a problem. How are you going to move people through a room with only one door and make sure that you don't miss the opportunities to vaccinate the babies? And some of the babies were being brought by elder siblings who didn't quite know what they were doing, right? So all these logistics had to be sorted out. And I remember Bernie and the team that I'm going to show you in a minute in our living room going through like the choreography. It was like ballet. Like, how are we going to get people into these clinics in these neighborhoods, take them through the triage, since the babies were coming, of course, at different ages and stages, needing different immunizations, through the triage to the right immunization and out the door again with the right treatment. So here are some slides that he took. He took photographs at that period that he doesn't appear in, of course, because he was taking all of the photographs. So you can see from the line, this was an incredibly popular program. When it got moving, it was very well well attended. So here's one of the doors in question. Here's the problem, that you had people crowding in at the doors. The solution: to create these lines, to have the directions of the movement very clear, to make sure that everybody knew where they were going. So we had triage. I remember these people very well. I keep thinking to myself, looking at the pictures, what are they doing now, these people? So triage with their cards, polio vaccine, smallpox vaccine, and eventually added education programs. And I thought that I could just give you this as just an example of the kind of detailed problem solving that I think Bernie has always done in our family as well as in his professional life. It's Bernie who knows who's got the airplane tickets. It's Bernie who's trying to figure out how to feed 3 children when their mother is away in fieldwork. It's Bernie who has got the nailed-down sense that if you're going to have big visions, you sure as heck have to have the choreography on the ground and the details and the logistics that will make that work. Otherwise, life itself will be a big missed opportunity, not just health. This work, which I'm not sure at all whether you all cite it anymore, but at the time, since he did the epidemiology of measles before and after, and showing the effect of this program on the general health of the children of Yaoundé, this was picked up by WHO and became one of the basic pieces of work for the expanded program in immunization, which was developed in the late 1970s and early 1980s. So it's been very influential in the long run, but I think kind of in its own way rather low profile in the splash. It created a momentum. It created a set of possibilities. I thought that I would just move to one further aspect of this program that I alone can perhaps tell you about, and that is that we became customers of it. So our daughter Kate, who is here in the little yellow dress, was born in Yaoundé in 1976, and she and I lined up with all the other moms for her shots. We didn't really do that for a photo op or for PR. In fact, we don't have a photograph of it. We thought that we might have, but we didn't. It was simply a case of, this is the best immunization program going. We're turning up. We're going to be there. We have saved, Bernie has saved, her carte sanitaire, her own immunization record. So you can see the detail of the thought that went into the card. So some of the mothers are not literate, right? So you have something about the baby in the pictorial representation, so that they can equate the developmental stage of the baby with the kind of vaccination that they need. This is the other side, growth chart, onward and upward. So I wanted just to use this as a simple illustration of the incredible importance that Africa has had in Bernie's career, and of course in our lives, in our family lives, to point out at the same time this incredible capacity to make things work, to make sure that things work, actually on the ground work, right? This was to be, and it will be now, a segue to Catherine Isabel Geyer-Fennell, who is our next speaker, this baby in the yellow dress. But I thought that I had one last word that I thought I would postpone, but I think that I'm going to say it now so the program moves along. And that is that so many of you are asking me, why is Bernie retiring? I'm getting all these little whispered questions. Why is he going to do? And I've thought up an answer which I've passed by him, and I don't think it's altogether wrong. And I'm very glad to announce it in the presence of his sisters who are here. that, you know, Bernie's parents came from the old country. So his father was an independent businessman his whole life, his whole career. So when Bernie graduated medical school, and particularly when he decided to go into public health, my father-in-law, Bernie's father, Sidney, he was nonplussed. Like, you're going to do what? You're going to be, he says it with this European accent, you're going to be a doctor with a check? With a check, you're going to be paid a salary? What's that about? Right? So my thought about Bernie's retirement now is that exactly 40 years after his graduation from medical school, he is finally going to live up to his father's aspiration that he be self-employed.
Okay, good afternoon, everyone. It's probably the only time in my life I'll talk to people who have seen my immunization record and my growth chart. But what I'm here to do today is not actually give my own thoughts about my father and his career, but I'm here to present a presentation from 4 very important people, as you can see on the screen, and I'm going to introduce them in just a second. Before we can do what we sort of put together, we wanted to just recap some of his accomplishments, but then add some of our own into the mix that were not represented here. So, you know, we've heard a lot of great things from so many people today, and a lot of great accomplishments, both in work that he has done, but also in work that the rest of you have done through his influence. So, we have some big accomplishments here. We would like to add a few. So in 1970, Dr. Geyer earned the title of Dad. That journey continued with 3 years later, Nathan being born, 3 years later, me being born, and then our family just continued to grow. And we added Amanda in 2004, we added my husband Bill in 2006, and then the last child to our family came in 2007 with Eliza. The next big accomplishment is 2005, when Dad earned the title of Papa. And that happened with the birth of Hannah Isabel, who's our family, has taken over my role as the family princess. In 2008, we had a trifecta in our family. In January, William Joseph was born. In September, Owen Wright. And in October, Jonah Solomon. And then we didn't want to forget that there are some accomplishments earned that came with the title of Uncle and Great Uncle Bernie to many. Okay, so now that we've added some accomplishments to the mix, we want to talk about our mission. So the mission for today was to evaluate the impact of Dr. Geyer's work on a very small but important sample. We wanted to redefine career as inclusive of family. We wanted to represent some of our family who couldn't be here. And let's be honest, we kind of wanted to show off his grandkids. So before we could evaluate his career, we first had to define it. And so, like I said, we really wanted to show that family and life were part of a career and not, they're not mutually exclusive. So we were actually surprised to learn that even the Oxford English Dictionary doesn't define career as just being your work, and it's just your course or progress through life. We also liked a few of these quotes. So Confucius said, choose a job you love and you'll never have to work a day in your life. Your work is to discover your work, and then with all your heart to give yourself to it. And then I think most insightfully, Mark Twain said, work and play are words used to describe the same thing under different circumstances. So also, before we could evaluate, we had to define his career, and then we also had to choose what our criteria were and how he defined success. So Papa's career is maternal and child health, with the goal being happy, healthy moms and babies. And we asked Papa how he defined success, and he said, to me, success is about really making a difference in people's lives. So let's evaluate. Our evaluation methodology, we selected a mixed method approach, a little qualitative, a little quantitative. For qualitative, we did in-depth interviews of Papa's daughters, the moms, grandkids, the babies. Some of our research questions, although you'll see there's a little inconsistency here. Did Papa do a good job in his career? Has Papa made a difference in your life? Is Papa great? And do you love Papa? Our quantitative study was a not-so-random sample survey of the three daughter moms and the 4 grandbabies. And then, of course, we're going to share with you the summary of our research findings and some conclusions. So the moms, in our interviews, we did some, we're going to share with you just an excerpt from each of our interviews. And Eliza said, although career is very important to Bernie, I've always had the impression that family comes first. When we Skype with him and Jane on the computer, he easily switches from talking about adult things to putting on a grin and singing Twinkle, Twinkle, Little Star with Jonah. He has reminded me by example to take things a little less seriously and just have fun. You can buy kids a million expensive toys, but really their favorite ones are the ones they have to use their imagination for, and what Bernie really believes and practices this wholeheartedly. Next interview was with Amanda, and the excerpt from her interview. I have to say that I'm extremely lucky to have married into a family headed by 2 parents that have raised 3 kind, giving, and successful children. Because of that, I always savor the morsels of wisdom that the Geyers share about raising children. And over the past years, I've come to appreciate a particular gift that Bernie Geyer has in this department, which is a knack for refraining from giving parenting advice when he may really want to pipe in with his 2 cents, and moving ahead on giving advice when he thinks it would be beneficial and necessary. And my interview. Being a happy mom isn't about being happy all the time. It's about learning to be the best mother I can be for my child. My dad's biggest impact on my motherhood journey is reminding me that much of the parenting information and research studies out there are just guidelines to be applied in my own unique way to my own unique baby. He taught me that getting to know my baby as an individual is one of the greatest starts to being a happy mother and developing happy, healthy children. And of course, get them immunized. All right, so we did do interviews with the kids. Jonah, we're going to go from youngest to oldest here. So Jonah is 20 months, and I will play this one twice because it goes a little fast. Okay. Jonah was asked about Papa.
Yeah, Papa sang Twinkle Little Star with Jonah.
All right. Let's play that one more time. I had to hear it twice before I really,
Papa, sing Little Star.
Okay. All right, so that was Jonah. Moving on, we have Owen, age 21 months.
Does Papa take good care of you? Yeah. Has Papa had a good career? Yeah. Are you healthy? Daddy. Right. Do you love Papa? Yeah.
And back to his waffle. Okay. Next up is William, who is 2.5.
Okay, can you tell me your name? No. What's your name?
William.
William? And how old are you?
2.
2?
Yeah.
Okay, and can you tell me about your papa?
Yeah.
Is Papa a good doctor?
Yeah.
Yeah. Does he take good care of you? Yeah. Okay, now sit down. Do you think Papa has had a good career. Yeah. And is he a good papa? Yeah. And are you happy? Are you healthy? Yeah. Show me your muscles. Okay, you gotta go back in front of the camera. Can you say, happy retirement, Papa? I'm happy, Papa. Very good. Okay, go over there and say it. Papa. Can you say, happy retirement, Papa? I'm happy, Papa. What do you want to say to him? Anything else to say to Papa? What? Do you love Papa? Can you say, I love you, Papa? Love you, Papa.
And in case you're wondering, no, he doesn't ever sit still. Oh, hang on. Let me go back. Oh, no. All right, hang on. Got to jump through. All right, so William. Okay, and Hannah. Hannah's the last. And again, our little princess, almost 5 years old. Here's what Hannah had to say.
Hannah, do you know who Dr. Bernard Geyer is?
Papa.
Do you know what his job is?
Being a college teacher.
Very good. Why do you think he's a good doctor?
Because he helps people and make them feel better. He knows that it's important to eat for healthy dinner, even calories.
Do you want to ask him any questions?
Why is it important to stay healthy, Papa?
What are the things that you do to stay healthy?
You eat your supper, eat your dinner, you get exercise, you sleep, and you go.
Yeah. Is it a good idea to get your shots?
That's a picture of Hannah and Papa.
Who's Papa married to?
Nana.
Yeah. Does Nana take care of Papa, or does Papa take care of Nana?
They both take care of each other.
What's his favorite game?
Golf.
Is he good at golf?
Yeah. He likes to golf with his two sons.
Is he better at golf than his son?
Yeah.
Is he better at golf than me?
You're better at golf. Both of you are good golfers.
Thanks.
The work that I like the thing that you do, Papa. Happy retirement, Papa. I love you.
Okay. So we wouldn't be good researchers if we didn't share some of the limitations of our selected methodology here. So obviously the availability of participants was a challenge. We had really busy schedules, important activities like eating waffles, drinking, coloring. We had some limited language and comprehension skills of our participants. We definitely had to deal with some short attention spans. There was definitely a short time for field work. And lastly, there were some participants bopping around and acting silly during our interviews. In terms of our quantitative survey results, we had 100% happy moms with an N of 3. We had 100% happy children, 100% healthy children, 100% impact of Papa, N of 7. And an unintentional finding was we had 100% happy dads too. And again, we had some limitations to our quantitative approach. We had a pretty small sample size. We really didn't use a formal survey instrument of any kind. We had some limited language skills of respondents again, and we definitely had interview bias, and I think we might have had a bias sample as well. But we were able to come to some conclusions. So we have 3 conclusions or 3 truths. Papa has definitely made a difference in people's lives. Papa has definitely had a successful career as defined by the combination of one's work and family. And Papa has definitely left a legacy. So Papa's legacy. We asked him what his legacy was. And when he defined it as, legacy is not about any one thing, it's about people. It's about having the good fortune and the good sense to deal well with others so that they leave the encounter able to do their best work. I feel that's how my mentors treated me. I hope that's how my students and my colleagues along the journey valued their encounters. He also added that his 3 most rewarding experiences were Sam, Nathan, Kate, and their families. You can't imagine just how gratifying it is to see my 3 children with wonderful spouses and gorgeous little kids. It answers all of the questions you asked about legacy, definition of happy mom and child, and success. And really, is there any better legacy than this? So from your grandkids, thanks for all you do for us and for children everywhere.
Bernie, I have to congratulate you on the quality of the research skills that you've inculcated in both of your children who presented today. Your spouse was trained independent of your efforts, but your 2 children, to use, we didn't quite see all of the statistics, but to present such thoughtful data is impressive. I have a few closing comments, but I'll turn it to you.
Okay, give me a chance.
You have it.
How about turning the lights up? No slides, just turn the lights up. Wow, that really, I'm sort of, I don't know the terms that you all use, but I'm sort of overflowing with pride and with feelings, so it's a bit hard to, I've got 3 pages of comments here, but it's all worthless in terms of responding to all that. I just have to thank everybody, first of all, and not miss the opportunity to just say thanks to Bob, to the department. I asked for a big bash, and this is certainly, more than I could have wanted. Lots of people participated in planning this. Couldn't have been done without Grace Bigelow handling all the logistics and getting everybody parking spaces and sort of making sure that we had a little bit of food and so forth. A lot of friends who weren't here sent me notes that they couldn't be here, and it's just great to hear from people that I haven't heard from in a long time, and thank you all for attending and being here. I guess I just have a couple of comments. First of all, I didn't even know I said all these things that they had on all these slides. I'm glad somebody's collecting them. If they're useful, should publish them, But the one thing that comes across to me is something that I've always believed for a long time, ever since coming to, I've only taught at 2 universities, at Harvard and at Hopkins. And the thing that is really clear to me is that good students make good teachers. And that having students of the quality that we have here and the kinds of things you heard talked about today is what makes somebody to come out to be a good teacher and to seem to have a great influence on their careers and their ideas and their things. It's not really what we do. We just make sure we don't stand in their way. That's what we do, and allow them to really accomplish what they're able to accomplish. I loved all the gardening metaphors. I don't know if any of you know, but I have pear trees and apple trees in my little yard in Baltimore, and a couple of plum trees at the beach, and my great ambition is to grow trees. I mean, what could be more optimistic in life than planting a tree? So it's like having children and having great students. I have a few notes in the margin here. So I may be the only person, other than Anne, who has actually studied chikungunya virus in this audience. And I have several papers on chikungunya virus in Nigeria, and I'm glad to hear that reference. We once, a couple of years ago, there was the famous Hopkins African, what's it called, Jane? The African, what? Oh yeah, Hausa, it's called, the acronym. And there was a Ghanaian who said that the secret to a long marriage, and ours is now 44 years, and is at the beginning of the marriage we decided that I would be in charge of all the important decisions, and she would be in charge of all the minor decisions. And do you know that over 44 years there's never been an important decision to make? So I feel that way about life, and I feel lucky. I love her line about self-employment. I keep thinking that retirement has to be different than unemployment. That's the really important thing, that one can't feel as though it's all, sort of all over. I just have a couple of reflections on sort of so I've had my kids evaluating my career, which is kind of fun. When I sort of evaluate my own career, I'd have to sum it up in 2 words, which are exceeded expectations. So I feel really lucky, and I hope all of you in this audience feel lucky the way your own lives have gone. There's no predicting. We sort of set out on the journey, and it takes us places, and hopefully we make the right decisions, and it takes us to good places. I started out in a sort of working-class Jewish neighborhood in Detroit. My parents were immigrants, as you've already heard, and they worked incredibly hard for everything that we had, and they felt the best thing they could give us was education and a start. And I'm a product of the Detroit Public Schools and Sputnik. My first year of high school, the Russians launched Sputnik, and everything else changed. And I was in touch with my high school biology teacher, Alex Mercer, until his death just a few years ago, because he kind of launched me in a career that I don't think he or I ever knew where it would end up. I also have to give a lot of credit to, I went to college at Antioch College, which has seen better days, unfortunately. But I was there in the 60s during the time when it was an exciting place. We were involved in the civil rights movement. We were involved in the anti-war movement. We were affected by the sexual revolution. We were kids of the 60s. And the remarkable thing about that period to me is that we had absolutely nothing. We were just as poor as you could be. We had no material goods whatsoever, but we thought we could change the world. And I don't think we did, unfortunately, but we certainly have tried, and hopefully we've left the kind of legacy that will help those who you've heard today take the next steps. Martin Luther King was my commencement speaker in 1965. And my teaching assistant in chemistry in 1960 was a man named Mario Capecci, who won the Nobel Prize in Medicine a few years ago. And my TA in my embryology course was Stephen Jay Gould, who was a famous Harvard paleontologist and scholar and a friend until his death. I had very great fortune to take a year out in 1963 and 64 and go to Scotland, where I was a student at Edinburgh University, and a period when that was just a hotbed of great science. There were people working on DNA structure and on protein synthesis and on neurosciences at that point. And of course, I had the great fortune of meeting a young English woman named Jane Isabel Mason. So the rest is history. And we've been so lucky in our life to have such great children, and the experiences in Africa are really meaningful to everything that we've done. It's like Jane says, I don't think I would have ever selected a career in preventive medicine and public health. I don't think I would have ever, I would have probably just been an ordinary doctor in the suburbs somewhere if I hadn't sort of been fortunate enough to open that particular door and walk through it. So you've all been asking me, well, why are you retiring? So here are my glib answers, After 40 years, no more grant writing. So that has to be right at the. So Bob, I'll have.
Don't be sure, Bernie.
Oh no.
Do not be sure.
Oh no.
What's the next one?
I won't have a boss anymore.
That's for sure.
And even better, I won't have anybody to boss. That's another benefit. Another benefit is I won't have to sneak out of work to go off to the golf course. So that will be, and my golfing buddies are here in the audience, so that will be a good thing. But really, at the heart of retiring is just my belief that in institutions big and complicated like a place like Hopkins, the old generation has to move on and has to make room for younger people with new ideas, and they're going to change things. They're not going to do things exactly the way we did them. Listen to Xiaobin Wang. I mean, that woman is doing the most incredible cutting-edge science of anybody that I know, and I'm just proud to have been around when she happened to be a graduate student here, to be honest. But and some of the work that you heard presented today are being done, just the variety of it, and the young people who are doing it, they're the ones who really need to take us to the next steps of both the science and the policy and assuring social justice for children and families in the United States. So what am I going to do when I retire? So let me assure you, there's no bucket list. I'm not going to jump out of airplanes or anything ridiculous like that. As you can obviously see from the whole afternoon, my first, the great opportunity for me is that I'm going to be with my family, and somebody's got to take care of Jane. So she is busier than ever, and doing more than she ever has before, and it's up to me to sort of play the supportive role after all these years when she supported me. It's just prescient to hear our granddaughters say they take care of each other. Because I can remember when we were married, we were, it wasn't easy us getting married. Neither one of our families wanted us to marry out of our religion, and we were away from England, and her family was in England, and we were away from Detroit, and my family was in Detroit. But Jane's father said to me and said to us that the thing we had to do was take care of each other. So I guess we succeeded. So, in retirement, I'm going to continue many of my professional commitments. You know that I do a lot of work with the Institute of Medicine, National Academy of Sciences, with committees there. I do a lot of work with my friends and colleagues in Baltimore. And I think I now have, they all say to me, oh, great, now that you're retiring, you'll have time to do all these things that we want you to do with the City Health Department, the State Health Department. I hope people here will want me to continue to work on projects. I want to go back, continue to have my connections with Africa through the Gates Institute. And I particularly love the thing that Amy Choi and the Gates Institute is doing, which is capacity building. I mean, that's what it's all about. And that is giving people as much of the skills that you can, and allowing them to really take the next steps. And Africa is particularly a place that has a lot of brilliant people, and giving them the capacity to do what they can do and improve life in Africa is really worthwhile. I'm going to continue my writing and my talking. My current interest in early life. I've got a vested interest in early life. So that's what's really keeping me excited, and the things that I like to work on, the thing that I'm working on with Kamala right now. Only a few of you really know about my profound interest in Yiddish culture and in the lives of our parents in Poland before the war, and I continue to sort of do historical research and write about that period, and I'm active in an organization, a Landsmannschaft organization that continues to work on Polish Jewish life. I'm also very involved in the development of a new synagogue here in Baltimore, and there's lots to be done with that, so I don't expect to be bored. And then I'll be able to take off to the beach and the golf course whenever I have a chance and enjoy that part of my. So I hope I'll see some of you there. So one other, you'll indulge me, one other set of thoughts. Some of others have heard me say this, but one of the things I feel particularly influenced by and kind of proud and important to me is that throughout my life, both in my family and through my professional work, I've had tremendously close women colleagues. And I've learned a tremendous amount from them, and I've been very influenced by them in my professional career. of course, our mother, who I don't think we had a picture of her here, but she was a tremendous source of strength to all of us. She lived to 99, and she just continually, through her entire life, was a powerful factor in everything. My two sisters are here, Evelyn and Marilyn. So I've had an older sister and a younger sister to both be bossed by and to boss. You've heard from Jane, so you know that we've been a team for 44 plus years now. You've heard from my dynamic young daughter. You've seen my two daughters-in-law. You know my whole family already, actually, when you come right down to it. And my granddaughter Hannah, of course, is named for my mother, so that's wonderful. But also in this audience are some of the women that I've worked with through lots of places in my career. Sue Gallagher and Ilana Lescoyer that I worked with on injury in Massachusetts. I mean, we go back a long way, and I think we did an incredible work there. I don't think Sally Fogarty was able to come, or Debbie Walker, or other women that I worked with in the Massachusetts Department of Public Health, but they were very, sort of fundamental in my career, and I give them great credit. I could have never done any of the things that I ever did without all these colleagues. So here you know that between Donna Strabino, I've written more papers with Donna Strabino than anybody else that I've ever worked with, and I see Holly Grayson, and Cynthia's here, and Riley I don't think could be here today, but there are other colleagues that I have here at Hopkins that, they're sort of lifelong colleagues. We've kind of wrestled and thought about all these ideas for a long time, and again, I feel as though, my ability to have a successful career is really because that, they were sort of always there, and we always worked as a team, and that's what made it work well. So, I have to thank the department for such a wonderful afternoon. I've been totally here and in it every step of the way, and seeing all of you. I think we've got a party now to go to. I hope you'll do one thing, though, and think about one thing, which is that Jane and I have started a scholarship fund with the department so that we can continue to have the kind of students come to our program that we've had in the past. And who knows when the next really smart, motivated, intelligent, caring person will come through the door and be the next great leader and take over from all the things that we've ever done. So I hope you'll also think about contributing to our scholarship fund so that we can make it really meaningful. So let's have a party. Thank you.